Good morning, ladies and gentlemen. Before we start, can I get an indication? Is there somebody here from the National Department of Health? We cannot start before the National Department of Health is here. If you will bear with us, please. Thank you. Ladies and gentlemen, please bear with us for a few more minutes. Thank you. Good morning, ladies and gentlemen. Welcome to this public hearing. Before we proceed, if you haven't been quiet this morning, you have the opportunity to reflect for a few minutes, or moments rather. Thank you. Ladies and gentlemen, I would like to welcome all present, the members of this committee, the NCOP permanent delegate, the Honorable Njadu, will be joining us a little later, officials from the National Department of Health, officials from the Provincial Department of Health and Wellness, and guests, and in particular the Western Cape Women on Wellness in the gallery opposite me, and also the other guests in the public gallery. I would like to ask the members of the committee to introduce themselves, please.
Thank you, Chair. Good morning, everybody. Good morning, officials. My name is Christopher Fry. I'm a member of this committee.
Good morning, Chairperson, and good morning to everyone. My name is Ayanda. I'm a member of the Standing Committee. I'm Ayanda Barnes. Thank you, Chair.
Good morning, Chair, everyone. My name is Rachel van Vogel and a member of this committee.
Good morning, Dan Plato. Thank you.
Thank you, members. Are there any members online who would like to introduce themselves? I don't see anybody. We will then proceed by giving the officials. Sorry.
Good morning, Chairperson. Wendy Kaiser-Philander. Good morning.
My apologies, Chief Whip. Good morning and welcome. We will proceed by giving the officials from the National and Provincial Departments of Health to introduce themselves, please.
Good morning, honorable members. Good morning, Chair. Good morning, members from our community. My name is Mike Romwabelo. I'm from the National Department of Health in Legal Services Division. And next to me is Ms. Nantobe Kompanza from Pharmaceutical Licensing Unit. And I'm also with Tsepo Mantra from Litigation Unit in the department, and Helen Musiatlaha from Legal Services as well at the National Department of Health. Thank you very much, Chair.
Thank you, Mr. Mobelo. The Provincial Department of Health and Wellness.
Good morning, Chair and Committee. My name is Michael Phillips and I'm from the Metro Health Services Health in Western Cape Department of Health and Wellness. Thank you.
Good morning, Chair. My name is Hassan Mohammed. I'm a public health specialist working in the Western Cape Department of Health. Thank you.
Any more officials?
Good morning, Chair, and good morning, colleagues. My name is Karen Housem. I'm the Head of Finance in the Office of the Chief Director, Metro Health Services, Western Cape Provincial Health Department.
You are welcome. Thank you very
Good
much.
morning, Chair. Francois van der Walt, CEO, Paul Hospital.
Any more? Welcome to all present again. Sorry. Are there any more? Ms. Jamsi, were there any apologies?
There's an apology, Chair, from member Glass, the EFF member. Thank you.
Member Class, thank you very much. Ladies and gentlemen, the purpose of this meeting is to get public input on the National Health Insurance Bill, the so-called NHI Bill. It is Bill B11B of 2019. And I would just like to read for the record background information on the legislative process followed on this bill thus far. The bill was referred to the Standing Committee on Health and Wellness by the Speaker on Friday, the Speaker of the Western Cape Parliament, on Friday, 23rd of June, 2023. On Friday, the 4th of August, the committee was briefed by the National Department of Health on the bill, and that was done by Dr. Nicholas Crisp. In terms of public participation in this bill, the bill was advertised in the mainstream and community newspapers in 3 official languages to reach stakeholders from different communities. In addition, the notice for all the public hearings was sent to municipalities, relevant health stakeholders, and members of the public to come and give verbal and written submissions on the NHI bill. This committee is complying with Section 118 of the Constitution and Standing Rule 72 of the Provincial Parliament Standing Rules, which says, and I quote, "The Provincial Parliament must facilitate public involvement in the process of its committees as required by the Constitution." Close quote. The committee will formulate its mandate for the province based on the public input received during the public hearings on the bill. The committee appreciates all the stakeholders that are present in today's public hearing. The committee has scheduled hearings on the bill in Beaufort West, in George last Tuesday, in Caledon on past Wednesday, in Cape Town today, in Saldanha Bay on Tuesday next week, in Vredendal on Wednesday next week, and in Paarl on Friday next week. Stakeholders are encouraged to attend and give input on the bill. After the public hearings, the committee will then consider the input made by the members of the public and formulate the negotiating mandate of the province on the bill. Once the committee considers the provincial mandate on the bill, it will then be submitted to the NCOP in the National Parliament for consideration. Once the negotiating mandate is submitted to the NCOP, the committee will meet again at a later date to consider the final mandate on the bill and submit the final mandate report to the NCOP for consideration. Ladies and gentlemen, I will now hand over to the National Department of Health, Mr. Advocate Moabello, to give us a brief overview on the health insurance bill. Mr. Moabello, over to you. Thank you.
Thank you very much, Chair. Thank you very much. I'm going to do the overview of the National Health Insurance Bill. But first, I'll have to explain what is the National Health Insurance. So the National Health Insurance is a funding system, it's a funding model where the resources are pulled together to create a fund, the fund that will be responsible for payment of services rendered to patients at a health establishment which must be accredited and be registered with the fund. So in a simple language, the NHI will be like your medical aid, but it will be a mandatory payment, meaning members of the public are not going to contribute. It will be a public fund that will be funded through the government financing system. We will deal with the sources of income when I present the bill in few minutes time. So the bill in a long title, I normally like to read the long title because it tells you the summary of the bill. What is the bill all about? So this bill, called the National Health Insurance Bill, aims to achieve universal access to quality health care services in the Republic in accordance with Section 27 of the Constitution. Section 27 of the Constitution deals with access to health care at that level and provide for progressive realization of access to health care. So the bill also seeks to establish the National Health Insurance Fund. This is the fund where the money will be put. This is the fund that will be paying for the services at the point of service. It also provides it set out the powers, functions, and governance structures of the fund. Also provide for framework for strategic purchasing of healthcare services. So strategic purchasing of the healthcare services, in simple language, it means is paying for your medical bill. Once you have received quality healthcare services from a health establishment that is accredited and registered with the fund. Okay, so that is a long title of the bill. That is the summary of this law. That is what it provides for. It establishes a national health insurance fund as a legally defined organ of state. It legally organ of state. It means it is standalone. It is not a part of the department, but organ of state. So the bill seeks further to establish National Health Insurance Fund of South Africa, its functions, powers, and duties. It further provides for the control of the fund by the board. So in the long title, I talked about the governance structures. So the governance structure in this way will be by the board, because the fund will be the Schedule 3A entity of the Public Finance Management Act. So the bill will further deal with the appointment of the board members, the chairperson, how it's going to be governed, and most importantly, it will also define beneficiaries of services covered by the fund, including population registration. It will provide for the contracting of accredited providers of personal health care services and allows for the minister to determine the criteria for accreditation and reimbursement of the healthcare service providers. So the reimbursement, that is when the health establishment lodge a claim for the services that they would have rendered to a patient. So the contracting here is when the fund contract with the service providers, who are more likely to be hospitals, but in terms of the National Health Act, we refer to them as health establishment. This will include your doctor, your surgery, your pharmacy where you get your medication, for as long as they are registered with the fund and accredited. The accreditation will be in terms of the OHSC, the Office of the Health Standard Compliance norms and standards. So the bill has got around 11 parts, 11 chapters, and 59 clauses. We call them clauses because it's still a bill. So once it's enacted, we'll call them sections. So section 1, if you see in your bill there, it defines the terms that are used in the body. It consists of many terms. They are defined in the context of the bill. Section 2, clause 2 deals with the purpose, which is to establish and maintain a national health insurance fund in the Republic funded through mandatory prepayment that aims to achieve sustainable and affordable universal access to quality healthcare services. The fund will be a single purchaser and a single payer of the healthcare services. This will be done through the pooling of funds and strategic purchasing of healthcare services and goods from accredited and contracted healthcare service providers. So I'm going to stress this one. The fund is a single purchaser and a single payer of the healthcare services. And this will be done by pooling of funds and strategic purchasing of healthcare services and goods from accredited and contracted healthcare service providers. The Act will apply to all health establishments except the military health services and the state security agency. The military health services is a standalone organ of state in terms of the Defense Act. They've got a military health system. They have their military hospitals, their sick bays at various military bases throughout the country. And the state security agency is for a reason of security that their members will then be covered by their own medical system. The Act does not affect the funding and function of any other organ of state in respect of healthcare services until this Act is being enacted or amended. And where there is a conflict between that particular Act and this legislation, this Act will prevail over that, except for the Constitution and the Public Finance Management Act as far as the dealing with finances are concerned. To the population coverage, the fund, the National Health Fund, will purchase services on behalf of South African citizens, permanent residents, refugees, inmates, and specific categories of foreign nationals. It will also purchase healthcare services for asylum seekers and illegal foreigners. But as far as the emergency medical services and notifiable medical conditions and basic health services are concerned. So there is now a limitation when coming to asylum seekers and illegal foreigners. But for children, it will take care of them irrespective of their nationality. And for visiting people who are coming to South Africa, in terms of this new act, the proposal is that they will have to purchase their travel insurance for purposes of health coverage whilst they are in South Africa. Clause 5 of the bill provides that eligible persons must register with accredited healthcare providers or establishment. So the registration is not a requirement for a person to access the healthcare services. It is for record purposes. Remember, in terms of Section 17 of the National Health Act, the health establishment must put records, must have records of patients, and also for purposes of planning. Because once you know how many people are in your feeder area, you'll be able to plan, to do budgeting, to know that I am taking care of 2 million people here. And then in terms of the doctor-patients ratio, how many will be needed, and how many health establishment can be licensed in this area. So the registration is for that purpose. Somebody who's not registered but happens to seek healthcare services will be assisted, but then that person will be registered unless the triage indicates that this is an emergency, will be assisted and then be registered later. So meaning registration is not a requirement, but it is encouraged for purposes of planning. The newborns will be registered automatically at birth. And the supervising adult must assist the child-headed household to also register. So the whole system is going to use biometrics information and any other such information that the minister may prescribe. Meaning, minister may make a regulation regarding the data to be captured. The healthcare users will have certain rights. Amongst them will be a right to quality healthcare service free at the point of care. So this is in fact the gist of the National Health Insurance. Quality healthcare services free at the point of care. So you will go to the nearest health establishment, be assisted, and then they will the health establishment will then lodge a claim against the fund. The fund will then reimburse the health establishment in terms of the rates that the minister would have prescribed. The users will also have the right to get information relating to the fund, services, benefits, and personal information. So they will have a right not to be refused access on unreasonable ground. So there is a limitation in terms of what the fund can pay. The same way that the medical aid has got certain limitation, what they pay after you're being serviced by the service provider nearer to you. The users will also have a right to submit complaints when they have complaints against the fund itself or against the service providers. It is more likely that against the service providers, it will be the issue of norms and standards, for example. And then also for the fund, it will be in case there is a refusal to pay for the services that are being rendered. The last one is to have to purchase healthcare services that are not covered by the fund through complementary medical insurance. So you will have a right in case the fund does not cover certain services to have your own medical aid. Clause 33 here talks about what will be the role of the medical aid when the National Health Insurance is fully implemented in phase 2 in 2029. So the medical aid will still exist, but will only for complementary services. As I have indicated earlier, that the cost is free at the point of care. So users are not going to pay except if the services are not covered by the fund. So the National Health Insurance Fund will be established as a Schedule 3A public entity. And for that reason, is going to exercise powers and functions as prescribed in the Act. Some of the functions of the fund will be to actively purchase services and enter into procurement contract for goods. Also, timelessly to reimburse the service providers for the services that they would have rendered, to determine payments raised annually in a prescribed manner. So the money that the fund is going to pay for the services rendered will be determined annually and also in terms of the regulation. The fund will also monitor the quality and standard of the healthcare services that is provided. It will also liaise and exchange information with the Department of Health, entities, and statutory councils. It will maintain a national database of population, demographic, and epidemiological information. This term is big, epidemiological. I think you can assist. Oh, my friend here is a scientist. He understands what is epidemiology. I don't know. But here is something to do with, yes. So if you can exercise, if you have functions that you can do, you must also have powers so that you'll be able to exercise those functions. So the powers are also in the Act because the fund is what we call in law a creature of statute. It can only do that which is allowed in the Act that created it. That is why it's called creature of statute. If it does anything outside that, it will be considered as ultra virus. So the powers that the fund will have the powers to employ personnel and also purchase goods, services, equipment, land, hire buildings where they will be working from, and also related assets like any other state organ or a government department will have. It will also have to insure itself against any loss, damage, or risk because it is independent. So it can be sued, it can also sue. For that reason, it can institute or defend illegal proceedings. People can sue the fund. It can also sue people as well. And most importantly, it will negotiate the lowest possible price for services and goods in terms of procurement. As indicated earlier in my presentation, that the fund is going to be an entity that is governed by the board. This board will be accountable to the Minister of Health, but the board will be appointed by the minister with approval of cabinet. So minister will get a recommendation from the interviewing panel, and then he will take the recommendation to cabinet, and cabinet will then approve the appointment of the board members. The minister will also be able to remove board members, and also he may dissolve the board, and he will dissolve the board after an inquiry and with cabinet approval. So this is to avoid arbitrary removal or dissolution of the board. So we'll have to follow the procedure in terms of the law. So the minister will then appoint the chairperson, the deputy chairperson, that is governance issues in terms of who's going to chair the board, and the deputy chairperson as well. So the board, once appointed, will have certain functions and powers. Among them will be to fulfill the functions of an accounting authority as required by the Public Finance Management Act. So because the board is an accounting authority, it accounts to the minister. And it will also advise the minister on matters relating to the fund, including finance matters, administration, pricing, and any other that minister may require from the board. So the board will also define the type of report that will be required from the executive management. The executive management will be part of the administration that will be appointed by the chief executive officer. And the board will determine its own procedures, how it is going to operate. And most importantly, the remuneration will be determined by the minister in consultation with the Minister of Finance, because it's a financial matter. The board will also appoint the chief executive, who will be the head of the administration of the fund. The fund, remember, it has the powers to appoint the personnel. So those personnel will be appointed by the chief executive. The chief executive is appointed by the minister on recommendation of the board. He or she will be appointed for a period of 5 years, renewable once. And the board may also recommend removal of the CEO, because they're the one who are going to recommend that this person be hired as a CEO. The responsibilities of the chief executive officer, amongst others, including being the head of the administration, being the head of the fund administratively, will be accounted to the board. And I indicated earlier that the board accounted to the minister. Now the chief executive officer accounts to the board. And the board will perform functions designated, the CEO will perform functions designated by the board. Amongst the most important one would be to run an efficient administration, including human resources, will create investigative units, deal with complaints and corruption, and also to appoint the staff of the board. He will liaise with the district health management offices. He will also establish units such as planning, benefits, provider rates, and payment. So he is going to be responsible for the day-to-day running of the fund while accounting to the board. Okay. The board has given powers to determine its own procedures. It is also given the powers to appoint the committees of the board for governance purposes. It will have technical committees and advisory committees within the board, and they can establish board as they may determine. But the Act empowers the minister to appoint the many committees. There will be a benefits advisory committee, which will consist of people with expertise in medicine, in public health, health economists, epidemiology, is coming again in that term, the rights of patients, and others. So it will also serve a certain term. It will be 5 years renewable. And the second committee will be the Healthcare Benefit Pricing Committee, because we're dealing with issues of determining the rates. So there must be a committee that deals with benefit pricing. And most importantly, there will be a committee that liaises with the public. It will be called the Stakeholder Advisory Committee. So these are the advisory committees. They advise the minister on the subject matter of their title of their names. The minister at the national level will still have a role. In addition for him to appointing and facilitating the appointment of the board, he will also have a role of that of governance and stewardship of the national health system and the National Health Insurance Fund. The minister must also delineate the roles and responsibilities of the fund, the national and the provincial department, taking into consideration the provisions of the Constitution, the National Health Act, that is in the name of preventing duplication. As I indicated earlier, that the fund will be a Schedule 3A entity, so meaning it's not a part of the department, nor the provincial department, but it is an organ of state. So the national department will still play a role, in addition to the roles that are listed in the National Health Act. The national department will still provide guidelines for norms and standards. It will also coordinate health services, responsible for planning, development of public-private establishment, integration of annual health plans. This is very much important, because we're going to have the national health system. So the annual health plans will talk to the medium-term strategic framework for government. So the medium-term strategic framework will be implemented through these annual health plans, which will further be implemented through the APP, the annual performance plans, because the indicators in the annual performance plan must talk to the annual health plans, which must talk to the medium-term strategic framework for a particular, I think it's 6 years or so. This one is very much important. I'm going to take a little bit of time here. The role of provinces under the National Health Insurance. The provinces, including the provincial departments of health. So the provinces will manage the ambulance services, as currently the Constitution provides that the ambulance services and EMS is a provincial competency. So the provinces will manage the ambulance services. They will most importantly assist the district health management office in controlling the quality of all health services and facilities in those districts. The NHI is a model that will be implemented through the district health model. So the DHMO office will be a critical component in the successful implementation of the national health insurance. The province will also provide technical and logistical support to the district health councils and coordinate health and medical services during provincial disasters. When the disasters are declared for a province, that province then will have to coordinate the health and medical services in that province. But most importantly, the Minister of Health can still delegate to provinces as management agents and for the purposes of provision of healthcare services. And in those cases that the fund will contract with sections within the province, such as the provincial, tertiary, regional, and emergency medical services. So minister can still delegate certain legislative powers to provinces to perform on his behalf. Like the minister now, in terms of the National Health Act, is able to delegate the appointment of the board of central hospitals to the provinces, because the central hospitals are the national government component, not the provincial component. I'm coming now to the general provisions in terms of the Act, the role of medical schemes. Clause 33 in the bill, if you read it, it says that once the national health insurance is fully implemented, the minister will introduce regulation limiting benefits to services not to reimbursed by the fund. So minister will then issue regulation to deal with this matter. And the district health management office's role as a national government component must manage, facilitate, support, and coordinate the provision of the primary healthcare services for personal healthcare and non-personal healthcare at the district level. It will consist, there will be a contracting unit for primary healthcare, what do you call CAPS, in there to attend to procurement issues. Remember, I said that there will be contract that will be signed with the service providers who are accredited, because you must first be accredited before you can be contracted to provide healthcare services. There will be a health product procurement unit to facilitate and coordinate procurement of healthcare goods. The national health insurance will be implemented through the system where the health care providers provide service and the fund reimburse them. So for that, the healthcare service providers must be accredited in terms of or in compliance with the norms and standards from the Office of the Health Standard Compliance. So they will have to get a certificate from the OHSC to say this is the to say you are in compliance with the norms and standard. But then it must also be clearly indicated the minimum range of services. The extent of services that the healthcare provider can provide must be clearly determined, so that when payment and rates are coming, there will be no issues. They must also adhere to the national pricing regimen. So they must charge rates that are prescribed, and they will be they must conclude a legally binding agreement with a maximum of 5 years. Then it can be renewed depending if you continue to comply with the norms and standards. There will be a complaints unit in the fund that will deal with complaints from the members of the public. So the complaints must be lodged with the appeal, and they will be dealt with within 60 days, meaning the law forces the fund to dispose of the complaint that they received within 60 days. It will be adjudicated by the appeal tribunal, which will be appointed by the minister, and will have the powers of the High Court, which means the tribunal can set aside the decision of the fund, or it can confirm. But most importantly, if it can set aside the decision of the fund where the complaint was lodged. The National Health Insurance as a system, it is going to be funded through mandatory prepayment, meaning there is going to receive money before it can pay or it can reimburse the service providers. So because it's a prepayment system, then the Act provides that these are the sources of the funding, where the money will come from. The first one is appropriation. So that means Parliament may appropriate money for the national health insurance. For example, the fund, when it starts, it will probably not would have collected any. So then Parliament will have Parliament and the Treasury will have to pass a money bill to fund the initial operations of the fund. And the second funding source of fund may come from the general tax revenue. Also shift funds from the provincial equitable share. So meaning the funds will be shifted from the provincial equitable share into the fund. And also the conditional grants will then go to the National Health Insurance Fund. The third one will be the medical scheme tax credit, the payroll tax, and surcharge on personal income tax. So this is how the National Health Insurance Fund is going to be funded. This is where the money will come from to fund the scheme. Because there's going to be money coming in, there must be reports. So the fund and the board as accounting authority, they must then prepare the financial statement that must be accredited, so that must be audited by the Auditor General of South Africa. And the fund and the chief executive must also prepare the annual reports that must be submitted to Parliament and the minister. So this is now an accountability matter in terms of the fund. Because we currently have a system, the two-tier system, where there's a public health system and the private sector. Sorry, is the whole national system, but it has got a private arm and the public arm. So there will be a need, therefore, for transitional arrangement to happen to usher in the universal health coverage. The bill in clause 58 provides that we will have two phases, phase 1 and phase 2. Phase 1 should start in 2023, this year, up to 2026. So it means this law is long overdue, should have been passed some time ago, because 2023 is dying soon. So 2023 to 2026, this will be phase 1, in which health system strengthening initiative will going to happen, like the foundation for fully functional fund. That will be the establishment of the fund after appointment of the board. And then we'll start by purchasing personal healthcare services for the vulnerable groups. So meaning in phase 1, there will be a prioritization in terms of who is going to be covered. But because this is incremental, then it will be done gradually, starting with the most vulnerable groups, and then phase 2 will probably then start to cover almost everyone. So this is progressive realization of the health of the right to access healthcare free at the point of service. So phase 2, that is after 2026, then starting 2026 to 2028, we will continue with the strengthening of the systems that would have been in place by then to continue and fully implement it. And then once it's fully implemented, clause 33 in the Act will then kick in, where the medical aid schemes will now start to provide for complementary cover only, no longer comprehensive cover, as currently is the case. The National Health Act will affect other legislations. And in terms of the drafting convention, when there are many pieces of legislation that are to be amended by this act, it is done through the schedule. They attach a schedule to the bill. If you look towards the end of the bill, there's a schedule with columns. There are various laws that are amended, and the last column indicates the extent of the amendment. There is an amendment to the Medicines and Related Substances Act, to the Occupational Diseases in Mines and Works Act, to the Health Professions Act, Allied Health, Mental Health Act, the National Health Act, the Nursing Act, Traditional Health Practitioners Act. So those are amendments. Once this law is passed, those laws will be amended. But traditionally, the act is amended by its own. For example, if you want to amend the National Health Act, you will introduce the National Health Amendment Act. But this act or any other act can amend the National Health Act because it's still an act of parliament as well. So once the act is signed into law and promulgated, then this act would be amended to the extent as indicated in the schedule. I have come to the end of my presentation, but I'm going to recap what is National Health Act for benefit of members of the public who might have arrived after I have started. The National Health Insurance is a funding scheme, it's a financing mechanism, which is done through pooling of the funds. And then it will, in the language of the Act, strategically purchase healthcare services, meaning it's going to pay for your medical bills at the point of service. But there is a limitation in terms of what it can pay. It is not going to cover your nose job. If you want to have a nose like mine, sharp like this, then they will not cover it. But if your sharp nose like mine is broken, it will be a medical necessity. Then it will be covered. So that is the limitation in terms of what it can cover. So it meaning the clinician will decide whether the services that you require are medically necessary. So then if they think that no, you can live with this nose as big as it is, then if you want it, you will have to pay for yourself. So that is in a nutshell the National Health Insurance System. It is going to usher what we call universal health coverage. So meaning people will have the right to go to hospitals, to their doctors, to the clinics, but you're going to enter through the primary healthcare level and follow the referral pathways. And then the fee, the rates will be reimbursed to the service provider who would have provided your service. And most importantly, the service provider must be accredited. And once it's accredited, he will then contract with the fund. The fund is going to pay only accredited and contracted service providers. So those that are not accredited and you happen to find yourself there for non-emergency medical, then the fund is not going to reimburse. But if it's for medical, for emergency medical, Section 27(5) of the Constitution provides that no one should be refused emergency medical, and Section 5 of the National Health Care as well. So for emergency medical, even now, even if you don't have a medical aid, there's an accident next to the private hospital, they will have to take you to that private hospital and be stabilized before they can transfer you to a public health facility. So that is in a nutshell what we call the National Health Insurance, which will be a fund, the fund that will be funded through the general tax, the appropriation, the medical credit tax, and the personal income tax. So, Chairperson, I'm happy to conclude my presentation, and thank you very much for giving me time and listen to my presentation. Thank you.
Thank you, Mr. Mobello. This is the fourth time this week that Mr. Mobello has done this. Thank you. Would the Provincial Department of Health and Wellness, would you like to add anything, Mr. Mohammed?
So the HOD, the head of department, has asked us to attend, not to comment, but just to listen to the feedback given by the public. Thanks.
Thank you, Mr. Mohammed. Since we've started, we've been joined by some more members. If they would like to introduce themselves, please, for the record.
Thank you very much, Chairperson. I'm glad it's Bakubakufos.
Thank you, Member for Bakubakufos.
Good morning, Chair and everyone in the meeting. I'm Mesuli Kama. Just for record, Chair, I'm not late. I just had a meeting that was postponed and I thought I should come here.
You are both most welcome, late or not. Thank you. Ladies and gentlemen, just for procedural, the sake of procedural matters here, a copy of the presentation and the bill is available at the back entrance. And I also need to remind you that interpreting services are available in English, Afrikaans, and isiXhosa. You can use this device or this hearing earpiece with the device in front of you. Sorry, it's not available to the members in the gallery. And then if there is anybody in the gallery who would like to give comment, when we get to that stage, you are invited to please come down to the floor to do so. Ladies and gentlemen, I respectfully remind you that this hearing is about the NHI. It's not about service delivery or the lack of it, good or bad. We are talking about the NHI, and I would respectfully request you to stick to the matter at hand, and that is the NHI that we are discussing. When I open the floor to stakeholders and members to give oral submissions, I also wish to respectfully remind you that in the interest of time, I'm going to allow those who have already indicated that they would like to make a presentation or give input. I'm going to allow you 10 minutes each. Please submit your written submission to Ms. Jamche or through the sources that are available. But in the interest of fairness and to give as many people as possible the opportunity to participate in the proceedings, I'm going to ask you to keep to 10 minutes. And if you don't mind, I'm going to ask you to wrap up after 10 minutes if you haven't done so voluntarily. The following stakeholders have indicated that they would be giving input on the NHI public hearing. I'll just mention the institutions. The Financial Intermediaries Association of Southern Africa, Momentum Metropolitan Health Solutions, Business Unity South Africa, the Board of Healthcare Funders, CIPLA, the Children's Institute, CLICS, there's a Health Forum representative, Ms. Kivitz, and then Mediclinic. I will therefore open the floor and give the first opportunity to give input and comment to, as I have it here, Mr. Gray Feldman from the Financial Intermediaries Association of Southern Africa.
Thank you, Mr. Chair. The name is Gary Feldman, and I represent the Financial Intermediary Association. The Financial Intermediary Association is a trade association which represents 1,600 businesses across South Africa. And these are members of the financial services environment, and we collectively employ approximately 45,000 people and look after conservatively 1 million members of private healthcare, private medical schemes. Mr. Chair, up front, I would like to state that we have submitted a written submission, which is on record. And in our submission, we've gone into full detail around what we believe are some of the important barriers in this bill. In essence, we do support the goal of expanded healthcare, universal healthcare. That is what we do believe is the right of any South African public member, and ultimately we believe that it's important that there is rework of the medical environment in South Africa. We have ascertained and evaluated the current level of universal healthcare already in South Africa, which in certain instances leaves a lot to be desired, but we've also established the barriers for leveraging off this to enhance universal healthcare for all South Africans. Our collective evaluation is that the bill should address it in the communities that it serves, and it should not be centralized. We believe that by creating jobs at local level, you will be able to grow the economy at local level and take responsibility for delivery at local level. We believe it should be ward-based primary healthcare, that each region and province can then determine
what is needed and how to allocate the resources at ground level. The barriers of universal healthcare in South Africa are many. The funding and resourcing of the universal healthcare and the national bill is a concern. The funding is a challenge that I think has been raised by the Minister of Finance quite recently and does concern us as an organization. We believe that to roll out universal healthcare, we require a collective effort with sound policy decisions and not just one size fits all, but also a shared commitment to overcome different attitudes and different cultural beliefs might result in a better solution for all. We see private healthcare as a national asset, and organizations that are innovative and are basically delivering good service in pockets. We don't believe the private healthcare environment is sustainable in its current environment and needs to be reworked as well. We do believe in a two-tier system that people have a choice of the different forms of insurance available to them. These private healthcare organizations lead innovation and lead service delivery, which is world class. We appreciate the notion of a minimum benefits package, that everybody has access to a minimum benefits package. Moreover, the system should offer choice. People will have diverse needs, could self-insure, and do have preferences of how they go about that. In line with the vision, we're excited by the prospect of incentivizing employers to promote healthy workforce. So we believe that if employers are incentivized correctly, this would take the pressure off a public health or a national health, universal health system. This will foster a positive working environment, enhancing employee morale and well-being, and driving economic growth by company performances where they have a healthy workforce. The unfortunate consequence of the bill being pushed through as it is could face substantial legal challenges, which we are concerned about, because this will just delay the inevitable of putting in a universal healthcare system that is beneficial to the country and its citizens. The risk of a lengthy court battle cannot be underestimated. There may be lengthy uncertainty which results in providers withdrawing, providers being uncertain how they'll be contracted, what they'll be contracted for. Our proposal is to amend the current bill as a precautionary measure, but really it's a step to looking at future growth of the healthcare industry in South Africa. We propose a solution that's focused on amendments of the bill, that there are certain elements that need to be reviewed, and we look forward at constructive collaboration that prioritize health and prosperity of our nation. The FIA have submitted a number of proposals that should be considered as amendments to the bill to make sure it meets the needs of the South African population and of the resources at hand. In my closing remarks, I think the champion of the goal of achieving universal healthcare in South Africa is an important focus for the government, both at national level and at provincial level. As passionate advocates of positive change, we stand ready to contribute and to work with the various parties and give insights and support suggested changes and basically ensure that we have a transformative healthcare system in South Africa. Together, through determination, collaboration, and commitment, we can create a healthier, more prosperous South Africa. Thank you, Mr. Chair.
Thank you, Mr. Feldman. You did well with your time. I don't think I've introduced myself. I'm Gerrit Pretorius, and I'm chairperson of the Standing Committee on Health and Wellness in the Western Cape Parliament. Before we get the next opportunity for somebody who has indicated that they would like to speak, I would just like to indicate to all the others whom I've not named that you are welcome to have an opportunity after these presentations have been made to make your input by simply raising your hand. Thank you. We therefore now, and also when you speak, as Mr. Feldman has done, please state your name clearly. Thank you. And the organization that you represent. Next to speak is a representative from Momentum Metropolitan Health Solutions. Thank you.
Good morning, Chair, as well as all the members and attendees. My name is Ali Hamdullah. I am the CEO of Metropolitan Health. We are a business as part of the Momentum Metropolitan Health Group. I'm joined by our health strategist from our business, Dr. Bosso Steenekamp, who will introduce himself and do a presentation on our behalf. Thank you.
Thank you, Dr. Amjad. Chairperson, members of the public, thank you very much for this opportunity to present to you. We're humbled by being part of this important process that's happening in our country. Momentum Health Solutions is focused on the sustainable delivery of healthcare for more South Africans for less. We provide healthcare administration services for 2.8 million South Africans and for more than 8 million people in other parts of the world. We fully support the steps taken towards universal health coverage. And we absolutely think it is critical. We have to fix these problems in our country so that we can have access to care for all people. But achieving universal health coverage is not easy. Very few countries have actually succeeded in doing it well. It requires extensive collaboration between all stakeholders. That's government, NGOs, the private sector, the public. We all need to find a system where we could collaborate and make use of all the available capabilities that's present in medical scheme administrators, medical schemes, and medical care providers, so that we can apply this expert and well-developed health capabilities that have took decades, century. In fact, it's more than a century that it took to develop the systems to the current level, which really are world-class systems. The introduction of the NHI will reduce the provincial health budgets by about 28%. If you remove the provincial equitable share and those conditional grants all go away. That will weaken the provincial legislatures, and it will weaken the provincial health departments. All healthcare purchasing decisions will no longer be taken at the provincial level, but it will be made by the NHI fund. This reduction in funding of the provincial public sector could destroy it. This will be another blow on top of the current budget cuts, the compounded high levels of accruals, and the medical legal claims that the provinces face. Pilot studies must be done before these funds are withdrawn from the provincial budget's allocation. These pilots must show that it's feasible for a central fund to purchase equitable, quality, and affordable healthcare services for the population across all provinces with diverse health profiles. And we're particularly concerned about the rural poor. How is it going to happen that the central fund will support those people in these far-off locations? Provinces and government must do extensive work before the NHI can be implemented. Preparation for the purchaser-provider split, meaning that one entity purchases and the other one provides service, needs to be developed, and it is a complex technical piece of work that must be done, and it is required for the successful transitioning to NHI. The bill must be amended to allow for systematically planned gradual implementation, so that we only implement that which we have tested and found to be working. Clause 33 of the bill restricts the role of medical schemes and health insurance, and therefore reduces the availability of resources to fund universal health coverage. Section 33 restricts the role of medical schemes to that of a complementary cover only. This section is vague and does not contribute to the achievement of universal coverage. This means current private contributions to medical schemes, often subsidized by employer and firms, will no longer be available to fund healthcare, and taxes would have to be increased to be able to fund care. Low-cost primary care insurance is important to achieve universal health coverage. These products support millions of South Africans to access primary care. To raise the anticipated 200 billion required for the NHI, the VAT rate would have to be increased from 15 to 21%. Higher taxes to fund the NHI will contribute to lower income, higher unemployment, increased poverty and inequality. Higher inflation and interest rates, and lower company profits. All will contribute to lower standard of living. Chairperson, in addition to these, there's concerns have been raised on the alignment of the bill with the Constitution by many parties. During the consideration and deliberation of the bill in the National Assembly Portfolio Committee on Health, the Parliamentary Legal Advisor had cautioned and raised concerns that this bill does not meet constitutional muster. Concerns regarding questions of constitutionality will delay the reforms that are required to transform the health system. In this regard, the limitation of provincial functions is a concern. It is likely that the centralization of the provincial functions is not aligned with the principles of cooperative governance and intergovernmental relations per Section 41 of the Constitution. The bill may be challenged on its constitutionality, and as the bill infringes on the rights in the Bill of Rights. The establishment of a multi-payer model with cross subsidies from the young and the healthy to the sick and the old, and from the high income to the low income, will be easier to implement and maintain than immense disruption and disarray that would result from the enactment of the NHI bill. Chairperson, I just want to make clear at this point, there are many gaps in our system that needs to be fixed, but it is possible to amend the NHI bill so that we could actually do this easier and achieve better outcomes. Section 27 of the Constitution provides that everyone has a right to have access to healthcare, and the NHI bill in its current form infringes on this right to care in numerous ways. The bill reduces access to care for refugees and asylum seekers. It limits access due to onerous registration requirements, and it limits coverage to adherence to referral channels. It also limits access to care for medical scheme members in a manner that is inconsistent with the ruling of the Constitutional Court in the Grootboom judgment. The onus is on the National Department of Health to do a full review and analysis of the benefits of the NHI and the impact of the infringement of these constitutional rights. This has not been undertaken by the Department of Health. There are more prudent pathways to universal health coverage, and implementation of the health market inquiry recommendations is a solid starting point. The WHO has made it clear that the central tenet for health systems reform is that it is path dependent. That means reforms must therefore be homegrown. You must start with what you have and build and take steps towards universal coverage. The NHI bill fails to build on what is in place in the South African health system and will result in the provincial health departments being weakened and the centralization of many provincial functions, and the private health system being severely weakened without creating a plausible alternative. So, our conclusion, sir, we firmly support the steps taken towards universal health coverage, and we simply think it is something that must be done. Our country needs it. But we do think that the concerns we've raised, and which have also been elaborated on extensively in our written submissions to Parliament, must be amended so that we can implement a framework towards the achievement of an NHI system in South Africa that supports universal health coverage, that's sustainable and can work to provide healthcare services for us and our children and their children. We leave a schedule of proposed amendments to the bill for consideration by the committee. We've handed out hard copies and we've also emailed that schedule. Chairperson, thank you very much for the opportunity.
Thank you. Did I hear your name correctly? Is it Dr. Boshoff?
Apologies, I'm Boshoff Steenekamp.
Boshoff Steenekamp. Thank you. Member Barnes?
Chair, mine is more for clarity. From the two submissions, I made an assumption saying that they are saying that they are supporting the NHI bill, but with amendments. Now, Chair, if perhaps you can also help us here by giving direction of saying for the next speakers, are they supporting the NHI bill or are they not? So that we don't be like doing what I'm doing here, saying, okay, I assume this is what they are saying. Perhaps if you can give guidance on that one. Thank you, Chair.
You're putting me on the spot, member. Ladies and gentlemen, I think it's been clear with the first two presentations that there is support with the bill with, I don't want to call it conditions, but certainly amendments. If those who are to come and follow with their presentations, if you could take the cue from that to indicate either your support or your non-support of the bill. And if you do support it with amendments, please state so. Thank you very much. Next up is the
morning. It's a great pleasure on the eve of a famous Springbok victory to make this presentation to you this morning. My name is Stavros Nicolau and I'm a board member of Business Unity South Africa, BUSA as it's known. BUSA is the apex business body of South Africa, represents around 80% of private business, small, medium and large in nature. I'm joined today by my colleague on my left, Professor Roseanne Harris, who is the project lead within BUSA for NHI. We certainly welcome this opportunity to present our mandated position, and of course we do so in support of the NHI bill. However, like the previous two speakers, we have some concerns that a single fund approach is unworkable and will exacerbate rather than reduce the health inequality in our country. And therefore, we have proposed a few critical changes to the NHI bill in order to allow for both the private sector to support the NHI in a collaborative effort with the public sector. May I also add, Chairperson, honourable members, that our country is at its best when the private and public sector have worked together, and we have seen this historically. And we have seen it most manifest when Business Unity South Africa and Business for South Africa, which is the execution arm of BUSA, worked together during the COVID pandemic. During the COVID pandemic, Business for South Africa, working together with government, led by government and other social partners, responded decisively to the public health emergency that COVID presented. We did so inter alia by procuring critical PPE for the country, which was inaccessible, saving thousands of lives. And of course, particularly lives of healthcare workers who were in the forefront of the pandemic. We also did so by funding and assisting in the rollout and administration of the vaccine program. These were all government-led and coordinated initiatives that rapidly brought together the resources, skills, and expertise of both the public and private sectors, hence the successful result that we had. Lastly, before I hand over to my colleague, may I also mention, in the same spirit, Business for South Africa is working together with government as we speak on 3 priority projects, being that of energy, transport and logistics, and crime and corruption. We therefore make this appeal that the amendments to the bill allow us to continue working together, because that is when we are most successful as a country. Private and public work together. So in this spirit, I'd like to hand over to my colleague, Professor Harris, who will continue. Thanks very much.
Thank you, and good morning, honourable members. My name is Roseanne Harris, and I'm going to hope that you'll indulge me to cover 6 points in my inputs to you this morning. So the first point I'm going to cover is around the provincial effects. So Section 32 of the NHI Bill deals with the role of the provinces, and Section 58 of the bill includes amendments to the National Health Act, which transfer the majority of provincial health functions to the National Department and to the NHI Bill. Of course, that means that the funding for those functions is also centralized, and we've estimated that about 196 billion of funding currently sitting with the provinces would be moved into the fund, into the NHI fund, and into the National Department. For the Western Cape, that estimate is around 22 billion. So that will require massive reorganization of the health departments. In order to be able to claim those funds, they will need to then deliver services on an accredited basis, as has been set out in the presentation this morning. And we're just concerned that that planning that is required in terms of the impact on service delivery and in terms of provincial health personnel hasn't happened yet. That needs to happen, and we need to make sure that we retain and enhance those the skills of those health personnel. So that's my first point about the provinces. The second point is around the funding and the costings. And we're very concerned that after a lengthy period of deliberation on the NHI proposals, we haven't actually updated the costings since 2011. The World Health Organization is clear that health system planning for universal health coverage needs to consider realistic scenarios. And we really would like to be part of the process of contributing to developing these scenarios on a realistic basis. The WHO also says that we should work within the context of our existing health systems. We should build on what we have. So the National Department has estimated that around 200 billion will be required to be raised through taxes. The mention of personal income tax suggests that that's an increase of around 30% in what we're paying in personal income tax. And these kind of numbers have already damaged investor confidence and are having an effect in terms of our economic climate. But just to be clear that even raising an amount like that will result in funding per person that is only around a third of what medical schemes currently have. So the kind of limits to benefits that were suggested in the opening presentation would be fairly significant in order to be able to deliver based on that funding. It's also important to recognize that in terms of Section 77 of our Constitution, that changes to taxes requires that's the ambit of National Treasury, and that requires a money bill. So Section 49 of the NHI bill is in conflict with this and should be dealt with in a money bill. My third point is around the risks of the single fund model. So we've heard how the bill has set out a single fund approach, and that the NHI will be the single purchaser for all healthcare services. That means that it is entirely dependent on tax funding to cover the entire population, even the portion of the population that is currently paying for themselves. And it includes this shift in funding from the provinces into the fund and the National Department. This is not an efficient way of funding healthcare, particularly in a country with the resources like ours. And it's also not a way for us to make sure that we're attracting investment and stimulating innovation in the space, which we desperately need, because it's health technology and these kind of innovations which will help us to expand access to healthcare in our country. We also have an overall shortage of healthcare professionals in South Africa. And the challenge with a single purchaser approach is that once the fund has dictated the contractual terms, there's no role for healthcare providers who don't contract to the fund, and we'll lose them. And we can't afford to lose healthcare providers. In fact, we need to be investing in training platforms to build our healthcare personnel, to skill them for delivering care to our population. There's really no basis for restricting the role of medical schemes. This is a provision in terms of Section 33 that was only introduced in the 2019 version of the NHI bill. And there's no real reason for restricting that role. The kind of objectives that have been set out, including mandatory prepayment, can still be met on a collaborative basis without these restrictions to the role of medical schemes. So the single fund approach also comes at the risk of running at a deficit, of accumulating a deficit. We've seen this in countries like Ghana and Indonesia with a single fund approach. and that either requires a bailout from tax funding or a reduction in benefits. And these are the kind of things that a collaborative approach to building an incremental implementation can help us to achieve. Chair, my fourth point is around the constitutional issues. So we've noted constitutional points around the tax funding, and there's some other concerns that relate to the rights of users in terms of accessing care along referral pathways, particularly if they don't operate optimally. The current framing of the bill means that people will be prevented from accessing care altogether, even if they are willing to pay. And around 40% of South African households currently pay for care outside of the public health service when they struggle to access it. Recent judgments have also stressed how important it is that we demonstrably investigate these kind of concerns that have been raised. So we've noted that...
1 minute.
Thank you, Chair. We've noted that Section 58 of the bill amends other acts, and we'd certainly appeal to the committee to revisit these amendments and go through a due process in terms of considering their impact. So, Chair, perhaps to close, we believe that there are immediate opportunities for us to expand access to healthcare in South Africa that do not require this onerous limitation on the role of the private sector, but that we can actually build a collaborative structure that is going to enhance service delivery and achieve the Section 27 objective of our Constitution of progressive realization of healthcare for all South Africans. So we would appeal for the proposed amendments to Section 33 of the bill, as well as Section 58 and Section 49, to be considered by the committee in their further deliberations. And we would be very happy to provide and support with technical input to support those deliberations. Thank you, Chair.
Chair, just to conclude, honourable members, our submission is that there are a few critical amendments to the NHI bill that are necessary for the NHI framework to be both workable and for the private and public sector to work together. A sustainably funded NHI can dramatically improve and bridge the inequality gap in healthcare in our country. We have a world-class health system. Let's build on it and let's not diminish it. And now you will see after she presented why we said Malibongwe. Thank you.
Thank you, Professor Harris, Mr. Nicolau. And next up, in the meantime, we've been joined by the Honourable Njadu, the permanent delegate from the NCOP. You are most welcome, sir. Thank you for joining the proceedings. The next presentation will be by the Board of Healthcare Funders. You need a microphone. If you could perhaps come to the lady here between the professor and the lady here, sir. You may proceed when you're ready. Sir, can you please switch on your microphone and start from scratch if you don't mind? Thank you.
All right, sorry about that, Chair. She clearly shows that I'm not from this particular part. My name is Kayas Kosana.
You must use the opportunity. The politicians are silent now.
Yes, my name is Kayas Kosana, and I represent the Board of Healthcare Funders, which is BHF. BHF is an industry association for medical aid schemes. As BHF, we support the concept of universal health coverage. However, we do not support the NHI bill in its current form. To clarify, we support the bill with certain specific amendments. We have made a detailed written submission articulating the sections of the bill and the areas that we do not agree with, along with our recommendations. So today, I just wish to draw your attention to a few of those areas. There are at least two preconditions for access to healthcare. You have funding on the one hand, and then you have the availability of infrastructure on the other hand. And by infrastructure, I mean health healthcare infrastructure, your hospitals, clinics, health centers, as well as the personnel, medical equipment, the pharmaceuticals, and all of that is required to provide the service. The NHI bill presents the fund as a panacea to all our healthcare challenges. And that is not possible. It's misleading us. We would like to see the government place as much emphasis on the other aspect of healthcare provision, which is the infrastructure, as much as they do with NHI. Because even if we were to have the NHI tomorrow with all the required funds, our citizens will not be able to access the healthcare they require due to the lack of the healthcare infrastructure. The Minister of Health is quoted as saying that we require at least 200 billion to get our healthcare infrastructure to the state where it requires to be for our people to be able to access healthcare. We are not aware of any plans on how that money is going to be raised and what is the project plan to ensure that our public healthcare infrastructure is put up to standard and ready to be able to service our people when NHI comes into play. The second aspect we'd like to place emphasis on is that of funding of the NHI itself. The bill states several avenues or possibilities of funding mechanisms. The experts who have done the numbers and did the estimate are saying that if we were to look at one of those, for example, if we were to look at VAT, we would require to raise VAT from the current 15% to 21.5%. Now, this is counterproductive because we're saying we're introducing the national health insurance in order to alleviate pressure from the poor. Increasing VAT from 15% to 21.5% is going to do the exact opposite. It's going to make life difficult for the majority of our people. And when you look at the other avenues, such as the payroll tax, again, the estimates are that we require a whole lot more. So the numbers that have been bandied about based on people who've done the studies is that we will require at least 200 billion to be able to introduce the healthcare funding. Yes, the government is right. They are going to get access to those medical schemes, tax credits, but that amounts to about 30 billion rands, which is nowhere near the amount that they require. So the medical schemes industry is playing a huge role in assisting with the funding of access to healthcare in the country. And therefore, we do not believe that it should not be allowed to exist. And it is my third point, which pays particular attention to Section 33 of the bill, which states that once NHI has been fully implemented as determined by the minister, medical schemes will not be allowed to cover services that are covered by the NHI. Now, given that we're talking about universal health coverage, meaning a comprehensive or full range of services. The effect of this is that medical schemes will actually cease to exist because there will be nothing else left to cover except those jobs and all those cosmetic surgeries and Botox and things like that, of which those are actually not healthcare services, they are beauty services. They just happen to be provided by medical practitioners. So, as BHF, we reject Section 33. We believe that once health citizens have made their financial contribution to the NHI, it is up to them to decide how else they wish to spend their disposable income. This could include buying additional medical cover through medical aid schemes, dictating to the health citizens what they should do with their hard and cash is unconstitutional, and therefore we do not support that. Through NHI, the government is seeking to nationalize and monopolize healthcare funding in the country. Unfortunately, the government's record of running monopolies and funds leaves much to be desired. And I would like to give two examples on that. Today, and for the past 15 years, the country has been battling load shedding, a result of the government's monopoly on electricity generation. And guess who they are running for solutions? The private sector. In the medical schemes or medical funding sector, already the private sector is thriving. Why destroy it at the expense of the national health insurance? When eventually the fund itself collapses, you would look back to the very same private sector solutions. The second example, and that is that of a fund. The Road Accident Fund, a fund similar to what NHI is going to look like once it's finished, is insolvent. It is bankrupt to the tune of 322 billion rands as at 31st March 2020. Their results for 2021, 2022, and 2023 have not yet been published. And my estimate based on the trajectory of losses that they were making is that currently the Road Accident Fund must be bankrupt to the tune of over 400 billion rands. This is most likely the fate that awaits NHI. So the medical schemes industry should be allowed to exist along NHI to help alleviate such pressures. On the other hand, medical schemes, as at December 2021, had accumulated reserves of well over 100 billion rands. That is a sure sign of financial sustainability for the industry. So as an industry, we cannot afford for it to be legislated out of existence through nationalization. Therefore, as BHF, while we support the concept of universal health coverage and understand that the government is using NHI as a tool to achieve this, we propose that Section 33 of the NHI bill must be scrapped in its entirety. Medical schemes must be allowed to exist alongside NHI and cover everything that NHI covers. This will further alleviate financial pressure from the fund itself. Thank you.
Thank you, Mr. Skosana. Next up is the representative from CIPLA. Is CIPLA present? Doesn't look like it. The representative from the Children's Institute. We'll move on. The representative from CLICS.
Good morning, Chairperson. Good morning, all in attendance. My name is Bronwyn McCauley. I'm the Healthcare Services Manager from CLICS Retailers. As a retail pharmacy healthcare group with over 700 pharmacies providing healthcare services to all seeking it in both urban and rural areas across South Africa, we are in support of what the NHI wishes to achieve. As my colleague mentioned this morning, with the COVID vaccines rollout, our pharmacies had the opportunity to open up our pharmacies to people requiring COVID vaccinations, which was a great opportunity to see public-private partnership at work. Our passion is enhancing healthcare access with a specific focus on task shifting, which we feel should form part of the plan for health system strengthening. Task shifting being the movement of specific tasks from highly qualified health workers to health workers with shorter training and qualifications, just for clarification. We elaborated in our written submissions, especially with concerns on Section 33. Our goal is to champion universal healthcare coverage as a private retail pharmacy group. We are therefore committed to enhancing access to healthcare services as we have the workforce and infrastructure. Thank you very much.
Thank you, Ms. McCauley. Next up is the Health Forum representative, Ms. Kiwis. If Ms. Kiwis is not present, or the Healthcare Forum representative, we'll move on to Mediclinic.
Morning, Honourable Chair, Honourable Members. Thank you for the opportunity. I'm Clara Findlay. I represent Mediclinic Private Hospital Company, and I'm joined by Advocate Michelle Norton, who's Senior Counsel at the Cape Bar. For those of you that are not familiar with Mediclinic, we have a 40-year history of providing private healthcare services in South Africa, particularly focusing on the acute hospital market. We have over 50 hospitals in South Africa, as well as other services that we provide to patients. Mediclinic is fully in support of universal health coverage. We have been involved in studying the bill, participated in every single phase of development of the proposed legislation, and we have also submitted comprehensive written comments to this committee, which we trust will be taken into account. There are, however, serious concerns with the bill. We would like to address those concerns via Michelle Norton, but we do believe that there are mechanisms to fix it and trust that the committee will attend to those as well. So I'd like to hand over to Michelle.
Morning, Chair, honourable members. The key concerns which we wish to highlight today are constitutional, and we assume and expect and are confident that this committee will want to be assured that the NHI bill can achieve its objectives in a manner that's compliant with the Constitution. The risk is that if it doesn't do that, the resulting legislation or sections of it may well be set aside by the Constitutional Court. Now, there are three main grounds on which we say that the bill currently infringes the Constitution. The first is that it may breach the constitutional right of access to healthcare services, the very right upon which the bill itself is based. As you'll be aware, Section 27 of the Constitution protects everyone's right to have access to healthcare services. It imposes two kinds of obligations on the state. The first is a positive obligation to protect and progressively realize everybody's right within the state's available resources. And the second is a negative obligation not to take steps which are retrogressive, not to take steps which take away existing healthcare access. And if the bill is unable to achieve its objectives, for example, if there's inadequate funding or inadequate human resources to make this scheme workable, the state would fail in its positive obligation. If the bill results in reduced access to healthcare services, for example, if it takes away services which are currently accessed through medical scheme and the private sector, the state would fail in its negative obligation. And we've noted that the NHI white paper itself describes the bill as a substantial policy shift, which would necessitate massive reorganization of the existing healthcare system. Now, that immediately tells us that if there's going to be such a far-reaching upheaval of the existing system, the risks posed by it are enormous. And we say there are three key threats to access to healthcare services. The first is that there may be inadequate resources for the effective implementation of the scheme. You've heard a great deal about that. There are legitimate concerns regarding the availability of the financial and the human resources available to implement the NHI scheme. Our healthcare system is currently faced with a range of challenges and constraints: the weak economic outlook, the shrinking tax base, a critical shortage of human resources for health, and a complex underlying disease burden. We also have an overburdened public healthcare system, and everybody's right of access to healthcare services would be threatened if the existing system, comprising public and private providers, is uprooted and the NHI scheme cannot be effectively implemented. The second threat is a threat to the role and the viability of private sector providers. The private sector currently plays a significant role in the provision and financing of healthcare services. You will see in the written submissions that we've made to you that approximately 30% of total hospital beds in the country are in private facilities, and more than 50% of the output from nurse training programs in the country is from private institutions. Now, what are the risks to the viability and role of the private hospital sector? First, the contracting and the reimbursement frameworks in the bill do not accommodate private hospital participation. The referral networks, the service delivery models are all based on the assumption of the public hospital network system. The criteria for provider accreditation don't take account of the special structural features of private healthcare provision. The exemption of the NHI fund from the Competition Act produces the risk that the fund, as the single purchaser of health services, will be able to use its dominant power to force prices for healthcare services below the competitive level. And that, of course, would pose significant threats to private providers. And then finally, the most pertinent threat is that the bill limits medical cover to complementary cover. And we must look at a context where at the moment approximately 9 million South Africans currently belong to medical schemes, and those who are currently insured enjoy guaranteed cover for prescribed minimum benefits, and that's treatment for over 270 medical conditions and 25 chronic conditions. The bill would limit the role of medical schemes to complementary cover. What does that mean? It means that there would be 3 sets of services. There would be services which are in principle covered by the NHI, and in fact, in a particular instance, are covered. Then there would be services which are in principle covered by the NHI, but for one of the various reasons mentioned in the bill, for example, because the user hasn't followed the correct pathways, or there's insufficient, or there's a delay for the service, or the particular service is not affordable at the particular time, then there would be services which are in principle covered by the NHI but not covered for a particular individual. And the third category is the precluded services, those which aren't covered at all by the NHI. But the problem area is that middle area. And here we have to look at the prospect of a user, a person who currently, for example, a patient with chronic renal failure currently receiving hemodialysis treatment covered by a medical scheme. If NHI is implemented, this treatment would be available in principle, but it's an expensive treatment, and the NHI fund may not be able to make it available to everybody who needs it when they need it. And when that person cannot access hemodialysis under the NHI, in the scenario which is produced by Section 33 of the bill, that person wouldn't be able to have backup medical cover to access that treatment in the private sector. And we have in our written submissions given you references to key court decisions where it has been found that there will be an infringement of health access rights if a patient is limited to the public sector where the required specialized care is only available in the private sector.
1 minute.
Sorry, Chair?
1 minute.
1 minute, thank you. So the measures required to address the risk to access to healthcare services are that there should be a staggered implementation of the bill. It should be based on measurable milestones, looking at benefit costing and financial and human resources estimates, and the limitations on medical scheme cover should be removed to ensure a comprehensive and sustainable role for private providers in the scheme. The second constitutional ground I will touch on very briefly, it's lack of reasonable certainty. I think you'll have seen from many submissions that the bill does not describe with reasonable certainty the nature and the scope of the services which will be provided under the scheme and how registered users are to access them. The third constitutional ground is that the bill doesn't comply with the public procurement standards in Section 217 of the Constitution. Thank you, Chair. And you have our submissions in that regard in the written submissions that have been made available to you. I think Ms. Finley may just want to make a closing remark.
I think similar to the comments made by our colleagues of BUSA B4SA, We are fully committed to engaging with government to make this work. Thank you.
Thank you, Ms. Findlay, and thank you, Advocate Norton. Ladies and gentlemen, just for clarity's sake, I'm going to ask again, is the representative from CIPLA perhaps in the House? The representative from the Children's Institute? And lastly, the Health Forum representative, Ms. Kivitz. Are you here, Ms. Kivitz? Welcome. Are you close to a microphone? Ms. Kivitz, I didn't see what time you arrived, as long as you know that you have 10 minutes. I don't know whether you were here when I announced that, but you're welcome.
Honorable Chair, I respect the 10 minutes. However, we know it's very little for a submission, but what I have on my heart is what I will submit.
You're welcome.
So thank you for this opportunity. If we look at the National Health Insurance and we hear what the private health sector is saying, the Cape Metropolitan Health Forum is of the opinion that we need to fix the current dysfunctionality of the health system. And if we look at the dysfunctionality of the current health system, it's both in the private sector as well as the public health sector, where clients are not cared for in the manner that they should be cared for. What the National Health Insurance is going to bring is universal health care for everyone. So whether you black, white, or purple, you will be able to access health care at any health facility according to the Constitution. So the Bill of Rights says I have the right to health. It doesn't mean that I have a right to private health care if I can afford it, or public health care if I cannot afford it. And that is what is currently the status quo of health care in our country. And so if you're on the medical aid and if you had a good cover, you get very good health care. Seemingly, I don't believe that. I'm on a medical aid scheme and I didn't get good health care. And so I've just also been a witness to that of other people that's on medical aid. So for us as the communities, what the National Health Insurance is going to bring is an ease in any person's mind, whether you're in Timbuktu or whether you're in Blouberg. If anything happened to you, you will be able to access any health service anywhere in the country. The ambulance are not going to pass Blouberg Medical Center because you're not on medical aid and take you to Somerset. That's the status currently of healthcare in our country. And so what the National Health Insurance are going to bring is that rule and divide of health services for ordinary citizens in the country. And what we are saying, we agree with the National Health Insurance for everyone. Universal health coverage doesn't matter what color you are. If my 6,000 Rand that I currently pay for medical aid can go into the universal health cover, so be it. Because whether I get a private bed at Tygerberg or whether I get a private bed at Malamed, it's a bed. And all patients want to see at the moment is care. And what the medical aid is doing, if you can afford it, if your medical aid can cover it, you're in a medical aid facility. You're in net care. If your medical aid is depleted, you in any case go to a public health facility. So does it make sense? And I think that is what we need to weigh up when we talk about the National Health Insurance, is what is in the interest of the citizens of this country and not what is in the interest of the person that pull the purse. And healthcare is not a privilege. It's a constitutional obligation. And currently, Chairperson, I want you to just make an appointment with me, not with anybody else, with me. When patients, I just come from a complaint, of a medical aid facility. The medical aid is depleted, so the person must now be admitted to Tygerberg. There's no beds at Tygerberg for people that comes from a private facility. And that's the reality. So we are asking the Portfolio Committee and the NCOP. I'm not saying rush it, but it's 7 years overdue. Please, let our people that needs health service, whether it's in Malamet, whether it's in Kuils River, let our people get the treatment that they should. Let our people be cared for as they should. Let us fix what is currently not working in the public sector and the private sector. Let us collectively fix it and not exclude people because they cannot pay. Thank you.
Thank you, Ms. Kivitz. Ladies and gentlemen, we will now take questions from the floor. If you will allow me, I'm going to remind you again, let's stick to the matter at hand. We're discussing the NHI. And you are all welcome to speak as eloquently as Mrs. Kivitz. And as passionately. So I'm going to start on my right-hand side. If there are any hands, please raise your hand. There's at least 5 hands, 6 hands that I see, 7 hands, 8 hands. I hope it's all from different organizations. So I'm going to start with the gentleman over here, please. If you could state your name, sir, and the organization that you represent.
Greeting, ladies and gentlemen. My name is Michael Zondi. I'm from the ANC Parliamentary Caucus. I am here in full support of the NHI. I think it's long overdue. We've been seeing a lot of people suffering outside here. I'm also myself a victim of those one who were dismissed when I was treated cancer, the leukemia, my blood cancer, by the medical aids when my funds were depleted. So I am fully support of the NHI personally, and my institute, my organization is fully supporting NHI because it is in the constitution that section 27, everyone must have an access to health. But we've seen a lot of people denied by those people that they are working for the agencies that we don't know, because we don't know where's these people, why they are cutting off people in accessing the health facilities when they having problems. You will find out that if you are crashed in a car accident, if I have medical aid and my colleague here doesn't have a medical aid, they will take only me who have a medical aid and my colleague will die right on the spot. These people, they are evil. And I think this thing should stop from right now. From today onward, the NHL must be implemented. Thanks, Chair.
Thank you for that contribution. Next, the gentleman over there, please. Thank you, sir.
Thank you very much, Honorable Chair. My name is Bongi Kayakama from SANCO. I am the Deputy General Secretary, and SANCO represent approximately about 3.5 million residents in South Africa and also various civics in the country. In fact, I'm not going to spend a long time because I think the latter speakers have represented our organization very well on this matter. Shortly, I want to make an emphasis that we are in support of the NHI bill because it will put an end to the exorbitant prices charged by the private sector, hospitals, and specialists to enable every South Africans to receive a good medical care. And the NHI bill also seeks to put a balance between those who can afford and those who do not afford. Because the first question, when you are injured, you are required to answer a very pertinent question that verify your ability to afford, that says, do you have a medical aid? If you are found by whether, particularly the private sector, if you are found to be on the receiving end of affordability, then you are turned back. And then for your life becomes useless because your pocket does not speak to the kind of service that you require. So under NHI, people will no longer be expected to pay additional fees because funds will pay for the healthcare providers and full prescription fees. And we are saying firmly that the issue of the healthcare services in South Africa needs to change, and I think it is about that time. And we note that no organization here, Honorable Chair, that has been against the bill. So we are in full support, and we would urge all our communities to support it. Thank you.
Thank you, Mr. Kayakama. Next, can I, by show of hands, please? You can just raise your hand again. The gentleman in the red jacket, and after him, the gentleman in the black top. Thank you, sir.
Thank you, Honorable Chair. My name is Nkosomza Price by above. I am from the ANC Parliamentary Caucus, born and bred at Talakoban location. I'm in full support of the NHI bill. In full support on the basis that I believe NHI leaves no one behind, irrespective of the color of your skin, of your affordability standards, or of the background you're coming from. I also support it because I believe as a nation we spend huge amounts of money on healthcare for very few people and very little on the majority. Our total spending on healthcare is far more than any country of similar size as us in South Africa and as us as South African, and economic activity to ours. We need to spend more efficiently. The healthcare costs in the private sector are high and ultimately unaffordable. By working together, we can ensure lower costs and universal coverage for all South Africans, even for people like Nozima Sile, the mother who gave birth to me at Talakuba, who never ever had an opportunity to be employed and to actually afford what you call a medical aid. Now, this NHI will be for everyone in South Africa. That's why I say I full support it. And I full support it because by working together, I believe by working together, we can ensure lower costs and universal coverage for South Africans, for all South Africans. The Department of Health is committed to working with all stakeholders to realize affordable healthcare. Lower costs are a win-win situation as more patients will access healthcare providers. So in that regard, Honorable Chair, I want to say as a South African, I support NHI bill. Thank you.
Thank you, sir. The gentleman in the black top.
Good morning, Chair and the committee. All protocol observed. My name is Silverton Dushelo from Ward 19. I'm the ANC elections manager. As the ANC, it is no secret that we support the bill in line with our government's constitutional imperative of healthcare as a basic human right. Yeah, this is in line with our vision as the ruling party of a better life for all. We believe signing off this bill will pave way for all South Africans to free medical health care in a manner that is efficient, effective, and sustainable. Yeah, if this bill is passed and signed, it will lead to improved health infrastructure. Yeah, it is very critical for the government to transform and upgrade the public healthcare sector, but we must firstly eliminate the imbalances between the private and the public health sectors, which are currently skewed in favor of the minority serving private healthcare. This is a milestone in what should be continued struggle for quality healthcare for all. Today, Chairperson, we confirm and we give a mandate to the committee and the NCOP to move with speed for the legislation to be passed so that our Commander-in-Chief, the President, can put a signature and seal it. Thank you.
Thank you very much, sir. Can I just ask that if you are able to, if you could just put your phone on silent so we just make sure that there's no distraction, if you could. Thank you so much. The gentleman in the, I understand it's the gentleman in the cap. Yes. Thank you, sir. And then the gentleman next to him afterwards.
All right. Thank you, Chair. My name is Lutando Noklinisa. I'm from Kosato. Chair, I think having listened to the private health providers and the organizations that represent business, one wonders that as we mark the 75th anniversary, the unfortunate and painful anniversary of apartheid, if business had so much courage then in 1948 to say that apartheid would be unworkable and would effectively exclude the overwhelming majority of the people, and it would be an inefficient system of oppression. If they had courage then to oppose apartheid, maybe we wouldn't be where we are today. We are here today because apartheid created a system whereby the majority of South Africans were excluded from benefiting from quality education, quality healthcare, and so on. Today, we have to correct that. And unfortunately, those who have benefited and those who continue to profit from this unequal system do not want change to happen. They want our government to pass a law that merely tinkers on the periphery and not address the core contradictions in our society. And core contradiction in our society is that South African society remains an apartheid society in reality. Despite the fact that we have transformational laws that have allowed all of us to vote, the reality is that the lived reality of South Africans is that South Africa remains a racially and a class divided society. This bill must address that, and we are unapologetic about that. It's about time that South Africa changes. So as workers, we are in full support of this bill as is, and we are looking forward to the NCOP processing it so that it comes back to the NA and goes to the desk of the president to be signed into law. We are not threatened by the statements that the private profiteers will meet us in court. Of course, we'll meet you in court, but you must also remember we also have the streets. We'll meet you in the streets where you are not there. That's why we have this in front of me. You can see signatures that we've collected from ordinary South Africans who say they support the bill 100%. And we are not apologetic about it, and we'll submit them. We were told to Ms. Nomonde jumped. I don't know where she is, but I hope to. Okay, yes, there she is. So we'll submit this, and we continuously mobilize and organize in the street, and the streets will speak. The overwhelming majority of South Africans will speak on this matter, and they are in full support of the bill. So that's all. That's all I would like to say, Honourable Chair and honourable members. Thank you.
Thank you. Are there more hands on this side? The gentleman in the red top. Thank you, sir.
Yeah. Thank you very much, Chairperson. My name is Benson Renzo from the South African Communist Party. The SACP supports the NHI bill. And as the SACP, we believe that the NHI bill will indeed mark an end to an era of commodification of access to basic health care. Presently, access has become a commodity, and it is only accessed by those who are rich, who have money, and predominantly they are white. The SACP argues that we must ensure that the NHI becomes when it becomes a law, and that Parliament pass the NHI bill before the end of the year. For us, this is urgent. Government must move towards implementing NHI by establishing single and public administered NHI fund. That will guarantee health care for all as a right, not as a privilege, as also argued here. We must ensure that the NHI fund is adequately protected from the forces of corruption. Under the NHI, all South Africans will be entitled to go to the doctor when they are sick or receive health care where they need it, and this shall be free at the point of service. There will be no premiums, no co-payments, no user fees or doctor consultation fee. As one speaker indicated, many amongst us who are having medical aid have exhausted their day-to-day benefits, but they have not stopped paying. And I have no doubt in my mind that majority of those medical aid holders pay more than 3,000 a month, and they are still going to pay. Healthcare will be delivered closest to where people reside or work at an accredited health facility, whether this facility is public or private, clinic or hospital. We must roll back dominant role of the private medical schemes in the current health system. Medical schemes should not be allowed to cover services or benefits that are funded by NHI. NHI will be funded the principle of social solidarity, in which the rich pay more for health care for all South Africans. The implementation of the NHI is expected to take several years before it can be fully implemented, though during this transition, together we must ensure that the public health sector is and must be the backbone of the future universal and unified health system supported by NHI fund. We must, going forward, spend more on public health sector, not less to reverse years of fiscal austerity and budget cuts. And the SACP will say, people before profit, and forward with NHI, and down with budget cuts. And that the SACP does not agree with the sentiments which seeks to threaten or intimidate any move towards the implementation, be it such calls are from business, well-coordinated white business, well-established, or from the national treasury. We shall reject. And if an NHI is further delayed, as Kosato has argued, we are going to roll out mass actions to ensure that all of us, black or white, rich and poor, you have access to basic health care. Thank you very much.
Thank you. Are there more hands on this side? The gentleman over there, and then right at the back. This gentleman, you, sir, please. Thank you.
Good morning, Chair. My name is Sibo Khoma.
I am from Ward 52. Chair, I was listening to the presentations here this morning, and what is really interesting to me is to listen to the different sides from which we are coming from in terms of this argument. It just tells you that those who are not there, who do not feel the pinch, would not understand what is happening at Kaiser State Hospital as we speak now. And Chair, if you listen to people speak here, looking at the legal matters and how to tie them up, I agree that we must look at, because we are a constitutional country. But also, it must also talk to the people. We can't just look at this thing at one level and forget about the people. Chair, the crux of the matter here is the point that is made there by Mrs. Kivitz. It's either the people or monopoly capital. That is the difference. It's either we go and support business and forget the people altogether, or we look at people. Chair, we can't have a situation where everybody says that we are a free country, we've been free for so many years, but still health services are still racially divided as it happens currently now. Because the services in the black areas and poor areas is different from the services in the white areas and the affluent areas. And I think it should not be on how much people can be able are able to pop out for them to be able to get a service. Chair, the people of this country have been patient with us. They've been patient with us. We've been dragging all along on a number of things. We must be careful. Those that are rich and have money and sit there at the glass house must be careful that one day those that are below them would rise up. They must not think that because at this stage they're at that level and they get everything and think that nothing can happen to them. One day, those that are down there will rise up. And Chair, we know the streets. And when we get to the streets, we'll occupy the streets and we'll make sure that it happens. Chair, I support the NHI bill. And I think it's a bill that was supposed to have been here a long time ago. I think when I'm reading the bill, I don't see anything that says private sector must go. It doesn't say. What it either says is that there should be a working relations between the private and the public sector, and that there is room for both of them to continue servicing the people effectively. So, but it cannot be a situation where you are only get services based on whether you are having resources or not. I thank you.
Thank you for that contribution. There was another hand. Please proceed.
Good morning, Chair. I am Vanessa Katip from the Manenberg Health Forum. My question is, will provinces still get their equitable share from Treasury, or will it get funded only through the NHI for services provided? My second question is, have the package of services that will be provided by the NHI been defined? Thank you.
Thank you for those questions, Ms. Khatib. I will, at the end of the presentations, I will give the National Department of Health the opportunity to respond, if you can bear with me. Thank you. Are there more hands on this side? The gentleman at the back? Are you with a microphone, sir? Sir, are you with a microphone? Can you please move to a microphone? Thank you.
Yes, and an amendment to
Sorry, sir, can you introduce yourself, please?
my name is Stuart Collins. I'm from an insurance brokerage, and we are very active in the medical health side of South African life, where medical health has the best and the worst in the world. And that's why I really welcome something like this, where we're allowed to speak, but in particular, a section that refers to the opportunity to expand healthcare. I'd like to make that one amendment, and I've just lost my place. Objectives of the bill, item 5.1, and where it refers to social solidarity, to make one slight amendment where it says it refers to all, regardless of their social economic status, will benefit from a national system of healthcare. I'd like to change that to medical aid, to a national medical aid. And I believe that this bill will be more widely supported if we refer to the National Health Fund as a medical aid for all. And listening to some of the speakers just earlier about the rich and the poor, in South Africa, 10% of the wealthiest people own 70% of the wealth of South Africa. But on the other end of the scale, 70% of South Africans only own 10%. These are rough figures, but that's pretty close. So we have this incredible diversity. We've got the best health in the world. We probably also have the worst health in the world. You said ambulances drive past the Bloberg Hospital, which is a brilliant healthcare, but they take people to Tygerberg. We need to question, and I believe that this bill will answer that question. Why is it so bad? Why is treatment so bad at the Tygerberg Hospital, but yet so good at Bloberg? Why do we have this diversity? We don't have rich to address the issues raised by the comrades from the Communist Party. Most people are not rich in this country. Most people cannot provide for their retirement. Only less than 20% of South Africans are members of medical aids. The rest rely on government hospitals. And yet, 70% of specialists, medical specialists, serve the private industry. That needs to change, and the only way we're going to change it is by all of us, business and my comrades in the Communist Party, to give support to this bill. I would like to see on the issue of funding, I would like to see that medical aids continue, and that's in my interest because that's the business that I am and that's where I provide health. But medical aids contribute a portion of members' medical aid premium into the medical aid fund, into the National Health Fund. And also that government provides funding by contributing a portion of the SASSA grant members, or adding, makes a payment for every single SASSA grant member, maybe at 350 rand, I don't know, but a portion of the SASSA grant directly into the National Health Fund. And then we will be where someone, I think the representative from Momentum said, most countries haven't got it right. We are being given this opportunity to make it right. Thank you.
Thank you, Mr. Collins. Are there more hands on this side of the house? We will move to my left hand. Are there hands here? Sorry, lady, you've been waiting very long. Your turn, and then the gentleman over there. The lady in front, yes.
Thank you, Chair. I want to start off, first of all, by rectifying.
Name, please.
Oh, sorry. I'm Valdila de Vries. I'm from the ANC Robert Waterwich branch, Ward 46. I first want to rectify one of the speakers. I think it was from the Board of Healthcare Funders. Am I right? I just want to rectify something. I'm a person that follows the acts as it's been quoted, or in this case, the bill. He asked for section 33 to be scrapped in its entirety, but preceded that by misquoting what section 33 says. He claims that Section 33 will mean that medical aid will no longer exist. That's not what Section 33 says. Section 33 says once healthcare insurance has been fully implemented as determined by the minister through regulations in the Gazette, medical aid schemes may only offer complementary cover to services not reimbursable by the fund. Very different from the fact that medical aids will no longer exist, sir. So I just wanted to rectify that input first and foremost. Secondly, I follow on to that. I'd like to say currently some of these medical aid schemes offer services and they give big amounts for services which they know their members will not readily use and minimize the services that is most often used. That is why the members run out of benefits in most cases. It's the way that they package their services. Secondly, on to medical aids, I'd like to know whether when this thing is fully enacted, whether the contributions of members of medical aid schemes will decrease. And upfront, I should have said upfront that I support the NHI. And I wanted to remain the I in the NHI and not the medical aid, because aid means assistance and I means insurance. Insurance meaning that you will get it. You will benefit from it. That's what the I is for. I just want also to know some clarity in the bill on page, I think it's 29. No, it's page 28, section 54(1)(b). It talks about offenses and penalties. And I'd like the officials from the health department to clarify which persons they're referring to. Because in the preamble and in your input, in your opening remarks, you mentioned who all will benefit from the NHI in your opening remarks. But now, under offenses, for me, it's not very clear which are you talking about, the people who are being reimbursed for their services, or are you talking about people who are claiming services? Because it's not very clear for me. It says any person who makes a false representation with the intention of claiming healthcare services benefits from the fund to which he or she is not entitled. So I'd like to know who in this instance is not entitled. It is not very clear to me. Secondly, I also have a problem that you pegging the fine to 100,000, because I think that that shouldn't be pegged, because it would be an incentive to defraud you of R1,000,000 and be fined 100,000 rand. Doesn't make sense to me. So the people that has been saying that's been negative about us working or not working, we must look at two countries I would like to mention. The one is Cuba, where you get free healthcare and transport for a country that has suffered embargo from the USA for many, many years. And then you look at the USA, who has been, the oppositions has been opposing the Obamacare. And currently, the Congress, the opposition is holding the ruling party hostage in not passing the financial budget. And in that budget, it is about health care to the veterans, to the people that they're supposed to assist and so on. So for all those people that's forever criticizing South Africa and the government, I think that we must look outside of this country to realize how far we've gone since 94. We've gone very, very far, even in comparison to a first world country as the USA. You must go deep down and see what services, social services, they're not giving to the poor as to what we as a South African developing country is providing to the poor. Our safety nets of social support to the poor. And I think this bill and its act is going a long way in bringing about parity and equity. A lot of people have spoken about different sections in the Constitution. Not one person has spoken about the section in the Constitution. And the preamble of the Constitution of South Africa is for all who live in it. And I am, as I'm sitting here, a very proud South African. And I don't want to be classified by my color. I am a South African. And so, Chair, I support this. It has gone a very long way. And to all South Africans, I think we must also shift the way we look at our health. We must look at preventative more than curative, and look at how we live a more healthy life instead of how long the queues are at the day hospitals, which is very long. If you don't get to that day hospital before 6 and sometimes 5 o'clock, in order to meet the quota of 30 patients a day without an appointment, you don't see the inside of the hospital. And I think that this will bring about parity and equity, and therefore I support the NHI. Thank you.
Thank you for that contribution. The gentleman with the glasses.
Thank you very much, Chairperson. Dr. Paul Nkurunziza from the City Health Department of the City of Cape Town. And I want to pose a question to the National Health colleagues. There's some clarity we seek which is not in the bill. We render municipal health services. First of all, Chairperson, I've not been given a mandate to say the position of the City of Cape Town or the National Health Insurance, so you forgive me if I don't say one way or the other. The bill, almost in passing, mentions municipal health services in the definition under healthcare services D, where applicable provincial, district, and municipal healthcare services, but doesn't mention them anywhere else. And so it's not clear to us whether they'll be funded by the bill or they're outside the scope of the bill. So I'd like some clarity on that, please. Thank you.
Thank you. Are there any more questions on this side or contributions? Are there hands? Sorry, you would have to come down to the floor, please. You would have to come down to the floor, please. Ladies and gentlemen, if you can please help the people from the gallery coming in order to find a seat where they can be close to the microphone, I would appreciate that. Thank you very much. Thank you. Can we start with hands, please, and then we'll proceed from there? This lady over here, and then the two gentlemen over there, please. And there's another gentleman here and another lady there. The lady next to you first, please. Thank you.
Can I?
Yes, please proceed.
Okay. My name is Samantha September February. I'm the provincial treasurer from Nauru. As Nauru, we believe that the national insurance NHI is a progressive policy towards addressing healthcare sector crisis that the country is facing with. The two-tier healthcare system, which constitutes the private and the public health sector, is on the verge of collapsing. The private healthcare is characterized by high cost of care, which has made it access only limited to a few that could afford it. On other end, we have the public healthcare sector that is under-resourced and overcrowded, as it is to cater for the majority of the population that cannot afford private healthcare. While we are trying to build a more equal society, healthcare is very unequal. The amount spent on healthcare on each person for medical aid is 5 times the amount that is spent on each person who relies entirely on the public health facility. In the country, if the country continues with existing healthcare system that discriminate based on a person's social economic status, there will be no progress in addressing the triple burden of disease the country is faced with. The country's morbidity profile consists of HIV, non-communicable disease, persistent child diarrhea, and malnutrition, and interpersonal violence and accidents. And how we support the NHI because we want a healthcare system that is fair and equal. It is through the policies such as NHI that South Africa can be able to address the structural inequalities which have put majority of South Africans direct situations where include issues of access to quality healthcare. The NHI will provide a good healthcare for all through sharing of resources, financial and human resources among our people. The health benefits that a person will receive will be based on their health needs and not on how wealthy the person is. The NHI aim to achieve UNC for all South Africans. The talk specifically to financial health coverage. It aims is to provide equity and social solidarity through pooling of risk and funds. The problem with our healthcare system is not isolated to public healthcare. Therefore, the notion that private healthcare is good needs to be addressed because that is not the case. The country needs a transformation of the entire healthcare system, not just public healthcare alone, because the two coerce. In other words,
The functioning of one impacts on the other. A simple example of this is when those with medical aid finish their medical savings before year end and they have to use public healthcare. The same private healthcare does not cater for these individuals. Instead, they send them to the public healthcare to receive free care. Private sector event adversely affected the public sector, and hence it is not possible to separate the two and solve the problem individually. The NHI represents a substantial policy shift that will necessitate a massive reorganization of the current healthcare system, both public and private, and also derives its mandate from the National Development Plan in the eye of the country. Private healthcare. Private healthcare prioritizes profits first over the health needs of the patients. The health market inquiry by the Competition Commission painted a very good picture on how the private health sector is far from being good or functioning well. The report highlighted a lack of competition, high prices, with a few dominant players exerting control. The report also noted a rise in healthcare utilization beyond what can be contributed to the disease burden and severity, contributing to the increase in hospital admissions and escalating costs. The cost of private healthcare is spiraling out of control, with the results that the medical aid contributions premiums are increasing more than the consumer price index, while the benefits of patients are reducing at a very fast pace. This is only a sector in the social economic arena that is behaving so. As the National Department of Health indicates, by 2030, if nothing is done to the financial protection of households, middle income households are likely to spend a third of their income on premiums for medical aid. Government cannot simply sit by and watch this happen. A lot of money is spent on private healthcare while they only provide the healthcare service to a small portion, 60% of the population. The World Health Organization and the OECD have contended that South Africa is the only country in the whole world, where so much money is spent on health of so few people. The high cost of private healthcare has also collapsed medical aid schemes. In 2002, there were 141 medical aid schemes. Today, we are left with 83 and still counting down. Therefore, there is nothing good about private healthcare. Then it has actually become a financial burden to those who uses it. In the public healthcare, it goes without saying that our public health care is under resources and possesses a constraint in the provision of quality healthcare service. As much as the public healthcare is known for being unreliable, long waiting time, bad services, etc., the core of the problem is the lack of financial and human resource. There is a huge need for the equal distribution of resources between private and public health care, and we believe that the NHI will be enabled this through a single healthcare system for all. Majority of our South Africans depend on public healthcare. Even those with medical insurance uses public healthcare for healthcare services not offered by private health. And when they run out of medical savings, as things stand, the biggest killer of South Africans is TB. There is more than 400,000 South Africans being treated for TB each year. All of them, regardless of their social economic status, are treated by public sector. The private sector is treating none. The TB cure rate used to be 67% in 2009. It is now at 85% by 2016. The second biggest killer is HIV and AIDS. There's an estimated 6 million South Africans infected by the virus. The public sector treating 3.5 million of, whereas the private sector, despite of the huge resources that they command, is treating only 200,000. There is an estimated 1.2 million women who fall pregnant every year. The private health sector takes care of only 140,000 of them, with 80% of the specialist doctors. The public health system take care of 1.60 million with only 20% of specialists. This is all achieved by an under-resourced healthcare sector, and we believe that through the equal distribution of resources, the provision of quality healthcare to all will be achieved. The NHI will be able to provide the necessary healthcare service based on the health need of the population without people incurring any financial burden or having to wait hours to receive help. And that now submits.
Thank you, Ms. September February. The lady with the glasses next to you next, and then the gentleman with the glasses here, and then we'll come to you, sir. Thank you.
Good morning, Chairperson, and good morning to everyone present today. Just a point, can my human dignity not be dependable on the size of my pocket? Can my right to equality not be dependable on the size of my pocket? Because right now I can afford, but tomorrow I cannot. That means my human dignity will deplete based on the size, based on my affordability. My name is Siyathemba Sogobo. I'm from the ANC and I'm in full support of the NHI bill. This NHI bill, it speaks to the right to healthcare, equality for all, and human dignity. And not for the basis that I can afford, in the basis whether I am rich or poor. And it's quite clear in this room where our alliances lies. People, the private sector is protecting their pockets. To us, we simply want human dignity. We want our rights to be respected, the right to primary health care and the barriers of health care simply to be removed. And that is what the NHI is bringing forth to the table. Can I please be respected? That is why I am in full support of the NHI bill. Thank you.
Thank you, lady. We'll respect you even more if we can have your name.
I did introduce myself. I said my name is Siyathemba Sogobo.
Sorry, I didn't. I missed that. No disrespect. The gentleman with the glasses in front.
Okay. Good morning, Chair. My name is Lizo Kalipa. I'm from Ward 16 in East Refugee. We also support the NHI bill as it is, with regard that South Africa is regarded as one of unequal society in the world. And the health service also reflects that. It reflects an unequal access to services. So with the NHI bill, we are of the view that all of us as South Africans, black and white, we will, through the NHI, have access to quality health service. We are of the view that the NHI bill is the instrument in the hands of our people and their government to create conditions for all of the South Africans to be able to access quality health care. This will alleviate the problem of the 60 million of our people, of all South Africans, because we hear, what I'm hearing from here, from the medical aid, is that they will be talking of our 3 million of their clients, of which myself, as one of their former clients, I have also been a victim. I'm paid medical aid for so many years. And with time, I couldn't afford medical. I had to scrap my wife and my children from the medical aid because the charges were
sort of increasing year by year. So I couldn't afford that. And even now, I also scrap it for myself because I felt that with the situation that we are in South Africa, I can't afford a medical aid. Whereas with my mother, who's also chronic, I can't even pay for her. Is also only help that she gets is from the clinics. So my take here is that we support the NHI as it is, and we are of the view that amendments that are being suggested here are just a delay, a tactical or a delay tactic to ensure that the implementation of the NHI is further delayed and it's not implemented in this year. So we are supporting the NCOP and saying they must move with speed in ensuring that they pass the NHI bill as it is, so that our people can, in a short space of time, access affordable, quality health service. And we understand also as well that the NHI will be implemented in phases. And some of the challenges that have been raised here will be addressed with time. They will be addressed with time because it is not that these challenges will not be resolved. They will be resolved with time. So let's give the NHI a time. Let's give it space. Let's see it resolving the challenges as they come. And also let's all of us, private sector and the public sector and the business and civil society, to work together to ensure that we don't criticize something that is not even yet born, but we come up with suggestions that assist all of us in ensuring that the NHI becomes successful. In countries like South Korea, the NHI was implemented also there in phases. People can go and Google there and see how in the past 12 years that the South Korea has been able to successfully implement the NHI in phases, and the challenges that they went through and how they managed to sort of deal with those challenges. So if we have a kind of studies and also understand that NHI is not a South African phenomenon, it is an international, it has been applied in other countries. So let's also learn from other countries and see how we can sort of, or how their implementation will assist us as South Africans. So my appeal here is that let us, all of us, work to ensure NHI succeeds. Thank you, Chairperson.
Thank you, sir. The gentleman with the jacket in front, and then the gentleman with the green T-shirt behind him. I recognize you, lady.
Okay. Thank you, Chair. My name is Leshohonolo. My surname Livenia. I'm from the South African Communist Party. If you listen to the presentation mainly by Busa and other health facilities that are presenting here, there is an echo sentiment that there is a common view that they are sharing, which is the readiness of South Africa into the NHI. But that is tantamount to say that a farmer must never plow because it's not raining. Which means then that we will wait up until the conditions are suitable for us to implement the NHI. By the time being, let us neglect the poorest of the poor, the toiling masses of our people, because the conditions are not suitable or are not right for NHI. Public policy in its nature, it's not value-free. Hence, the private sector are coming gun blazing and threatening us with legalities because they represent their values, which is private accumulation, which is profit maximization, without looking at the aspects of the people, how the majority of the people in South Africa are living. For them, your sickness is your business, is their business. The more you seek, is the more they get profit. As an SACP, we are fully behind the NHI in its totality. Those who are saying that NHI needs to decentralized, they need to look at how the Western Cape is handling it. How stratified are the services in the Western Cape? Do you think people who are willing to shoot taxi drivers can provide you health services if we are decentralizing it? Do you think people who have this vast suite of the distribution of resources can care about people who are living in Endovin to get quality healthcare? We as SACP, we are saying that South Africa is not a federal state. It's a unitary state in which a single centralized procurement is suitable for the bill. We support it. Thank you.
Thank you, sir. The gentleman behind you.
Thanks, Chair. And good day, everyone in the House. My name is Nkoti Malega from Ward 69 in Masiphumelele. We fully support this bill, NHI bill, as the residents of Masiphumelele. I would like to take this opportunity to, after listening to the presentation and the comments of people in the House, that mostly those who are from this medical aid scheme, I think, according to my view, they've missed the point. And there was my comrade here, Comrade Kroma, who tried to rectify and show them what this bill's intention is. It's not to substitute the medical aids. They missed the point. Hence, they came gun blazing. On our organization, in our organization, the preamble charter, in the Freedom Charter, they say people shall share in the country's wealth. Those who are wealthy, they must share with those who are not wealthy. Hence, this this initiative of the bill, of the NHI bill. And my lady just left here. She also mentioned the preamble of the Constitution with the access of quality health care for all, which is there in the Constitution. So, Chair, as the residents of Masiphumelele, we have also collected the signatures within our communities, which are with our leaders there to submit them to your office chair in support of this bill. Also, just to reflect on the presentation which was made by the Department of Health this morning, I heard the people are concerned about how this NHI going to be implemented at the provincial level, at the district level. Is there in the presentation? Maybe they came late. They missed that part of the presentation, because it's there that there will be district health management office in the district level, where their responsibility will be to facilitate, support, and coordinate the provision of the healthcare service. So, and it also went further to mention that the national health, the national NHI bill will also, once it's fully implemented, the minister will introduce the regulations, which is, these are the procedures of the implementation of the bill once the bill has been signed by the president. So, as the resident of Masiphumelele, we fully support this bill. Also, just to add, there was my lady here mentioned that the medical schemes represent the population of 9 million in South Africa. So we have a 60 million population in South Africa. So why that they don't cater the 61 million of the population? This is the intentions of the bill, to cater for those 61 members of the societies which are sidelined by the medical aid schemes. So also there was my brother, Mr. Skosana. Mr. Skosana was saying, how are we going to get the funding for the bill? As I've mentioned, people shall share in the country's wealth. That's where we are going to get the funds. That's where we are going to get the funds. This country, my other ladies mentioned that we are filthy rich with minerals and whatever, everything that we have in the country, and there's the investment, business, foreign, you mentioned them. Those people are being taxed. Those taxes will be used to fund this national insurance bill. So my brother, I don't know, because this bill is intended for our people, also everywhere across the country. Abo tatu Mashangu, abo tate Msiza, ekhaya, le kwamshanga, sibuya khona, Mpumalanga, Limpopo, kwaMashanthane, Kamasemola, Kamutubatuba, Tubatsi. All these areas, those people will be catered by this NHI bill. So, Chair, I'll stop there. We fully support this bill. Thanks.
Thank you, sir. There was a lady at the back who had her hand raised. Was it you? Sorry. Please proceed.
Good day. Thank you, Chair. My name is Jackie Marman. I'm from Mitchell's Plain. I'm a staff member of the Mitchell's Plain PCO. I'm here to state that I fully support the NHI bill, and I mean, coming from for 16 years, for more than 15 years, 16 years, I was on medical aid. I was working and I was forced to take the company that we were forced to take a medical aid. And yet the medical aid continued to fail me dismally. Like there's a gentleman that did mention that you pay a medical aid every day, every month. And yet when you need it the most, you're told that your funds are depleted. you get a frame, you only go for your spectacles and then your funds are depleted. You can't even go and extract your tooth. So with this bill, it caters for everyone. It doesn't choose sides. It doesn't pick whether you have enough funds or not. And currently I'm no longer privately, I'm now under the public sector. And I must say that the treatment that I've been, the medical treatment that I've been under while on private, I'm getting the same medication under the public sector. So for me, there's not much of a difference in terms of the medication that I was getting. The same treatment that I was on while I was on private, I'm getting it now for free, whereas I was paying the whole time while I was on medical aid. So this NHI bill, it caters for everyone, and I'm in full support of it. Thank you, Chair.
Thank you very much. The lady at the back.
Well, Chair, good afternoon. Honorable members of this House, the public in the gallery. I'm Adrian Williams, PCO 620, Grassy Park. I'm actually a guinea pig from apartheid till now. I was born with an open heart, a hole in the heart, and I had open heart surgery at the age of 2.5. And the wonderful part is that the public hospital did it, Red Cross. I was only 7 years treated for my heart condition. Thanks to my father's knowledge on what God has put on this earth as well. He didn't believe much in the westernized medication. He changed my diet, my exercise. He took very much good care of me. That's why I'm an earth child. I believe still in that. Up till today, I'm 48. No heart medication. No medical aid. A couple of years back, I collapsed at work. I was rushed to Constantiaburg. As I entered, I was asked the question, medical aid. I said, no. I spent 3 hours, 1,000 rand later. There were conditions. You get 90 days to pay it off. I said, what happened after 90 days? Well, our advocates will make contact with you. You will receive your letter. That same weekend of getting the treatment from Constantia, we called in and say, I'm not getting better. They said, well, come in. I refused to. Come to a Mitchell's Plain doctor, pay that practitioner with no such equipment as what Constantia Burke have. And that what he gave me actually assisted and got me back on my feet. And within 3 days, I was back manufacturing novelty candy. So, ladies and gentlemen, our healthcare system in the public arena has been done very good work. And I'm still alive today on the processes and how they treated me for the first 7 years of my life. And by the way, I was born at Victoria Hospital. Thank you very much. I support the bill.
Thank you so much. There's a hand over here, lady. Please proceed. I recognize you at the back as well.
Goeiemiddag, ek is Afrikaans gemengels. Sit maar die oorplakkies in. My naam is Aletta Lottering en ek is gemeenskapleier in my veld en waar ons ook partnerships bou met sekere organisasies soos die gesondheid. En vanmiddag is ek hier ook om ons krisis na vore te bring. Ek ondersteun hierdie bil, soos ek nou al gehoor het, al die uitsprake wat gelewer is. Dit is 'n mooi ding wat ons kan saamvat vorentoe. Maar as ons hierdie bil kan trek tot by ons gesondheid, daghospitale, dit is baie scary. Om te dink jy is kroniek, om te dink jy ly aan sekere soort siektes, dan moet jy 4 uur in die môre, 4 uur, daar is nie vervoer of jy het nie geld vir 'n taxi, vir 'n privaat taxi nie, jy moet stap deur jou area, deur jou wijk, om by die daghospitaal uit te kom. Die daghospitaal se hekke maak 7 uur oop. In die reën, in die winter moet jy daar staan. Daar is nie onderdak nie. Jy moet staan in daai nat weer of in die son wat nou gaan opkom, moet jy staan. So ek vra vandag, ek skree uit vir help. Ons daghospitale maak ernstige support. Ons is by 'n daghospitaal waar daar nie 24 uur is nie. Jy moet van jou af beweeg, moet jy na 'n daghospitaal toe gaan waar 24 uur vir jou kan help. Jy's by 'n daghospitaal, hulle werk van maandag tot Vrydag, 4 uur maak hulle toe, 3 uur begin hulle al te vee. So asseblief tog, ek smeek asseblief, laat hierdie bil ook praat rondom ons se daghospitale, sodat ons hande vat en the way forward kan aanpak. Dis 'n baie mooi bil wat vir almal 'n benefit kan wees. Chronic krippel of krom, dit kan vir ons almal help. Baie dankie.
Thank you. The lady with the glasses.
Morning, everyone. I just want to, my name is Letoya Nzimande. I'm from Manenbeek in Tambo Village. I am in support of this national health insurance. My question is, as the person who stays in the community, being with the grassroots level people, some other people, I can say that I may understand about NHI, but what about the person who doesn't understand what are we talking about? I just want to find out from the government that is there any a mechanism or things that you put in place to teach people to understand more, because now it sounds very nice that there will be a health insurance. I can go to Melomed, I can do this, but other people, they really don't understand. People, I think they need to be taught, and then we need to have a public workshops for everybody in each and every community for people to understand. And another thing, that what about the communities in the rural areas? Do they know about this thing? Are they going to be able to access the health facilities? Because if you go out, let's say outside Cape Town, those who are working in the farms, do they understand what is this? And then under this insurance, I mean the government, are you gonna be able to improve our facilities the way they are? Because if, let's say, Kukuletu day hospital, they are registered, they I mean, like, they get, are you gonna improve those facilities rather than us leaving Kukuletu or leaving Manenbeek and go to Melomed or go to other places? So that's my question. And then my question is about the education, because in radio station, it's just like they talk about NHI, but they don't go deeper. And the languages people, I mean, the languages that people need to be taught to understand. Because I'm talking, like, I'm hearing everything is honky dory, but I'm worried about that person who's sitting there who don't understand a thing about this thing. Thank you.
Thank you. Ladies and gentlemen, just for clarification, we will answer the questions, or I'm going to ask the National Department of Health to answer the questions once we have completed the presentations and contributions. The lady next to you, do you also wish to speak, lady?
Yes,
Please,
Chairperson.
please proceed.
Good afternoon, everybody. My name is Halima Isaacs. I'm come from Manenberg Health Forum. We support the bill, but there's just one thing that nobody has spoken about today. I haven't heard anyone saying how is the fund going to be split. Because if you look at the public sector, we have more people using the public facility than what people is using within the private sector. So if that is going to be split 50-50, then that would be very unfair in my opinion, because of, if you look at, for instance, people would use the private sector more because they think that the services is better. But that money will be used more in the private sector than the public sector, because then at the end of the day, we might not even be able to continue with the National Health Insurance Fund because of how the public sector, a private sector will be using the monies that is being given to um, both sectors. So we need to think out of the box about that. If it's 50-50, we got more people in the public sector that is using the hospitals. So but we support the National Health Insurance Fund.
Thank you. Are there more hands? Lady?
Um, Chair, I'm Vanessa Kati from the Manenberg Health Forum. I want to know, will there be two health budgets, one for health infrastructure and one for health services? Thank you, Chair.
You had two other questions earlier. What were those? You had two questions earlier. Could you repeat those, please?
Will provinces still get their equitable share from Treasury, or will it get funded only through the NHI for services provided? And the next one was, have the package of services that will be provided by the NHI been defined?
Thank you. Are there more hands? It doesn't look like it. Mr. Moabella, will you be responding to the questions, or one of your colleagues?
Okay, Chair, I will try to answer. I will start with the one that we just know about finance, about whether there will be two budgets, whether the budget will be split. Remember, the NHI fund is going to be a financing model. So being a financing model, it is national. It is going to be implemented through the district health management offices. So there is going to be one budget into the fund, and the fund is going to distribute to the district according to the needs, according to the health needs of the district. That is why the clause 5 talks about registering, so that there will be planning. There will be any indication that district number 49 has so many people, then it has got so many health establishments. Then in terms of that, then the fund will at national level then distribute to the district according to their needs. And I think there was an issue about the package. We have indicated that the minister will indicate that there is a benefit advisory committee that is going to advise the minister, and minister will issue regulation to determine that. But NHI will not really have a package. It's going to be universal in the sense that the services to be reimbursed for will be determined by the clinician at the point of service. Indicated earlier that if I've got a broken nose, then the doctor will say this is necessary because now I need to be treated for my broken nose. But if I have a big nose, I want to make it sharp, then it's no longer a medical necessity. Then it will not be covered. So there was issue about the provincial equitable share. The bill in clause 49 say that there will be a shift from a provincial equitable share. That is exactly what it's saying in terms of the budget. Let me go back and try to see other question. Okay, there's an issue about education. So we present the bill as passed by the National Assembly to the NCOP. The comments and inputs made are not for the department because we cannot do anything as national because the National Assembly has passed the bill for us. It is a Section 76. It is here as a second leg for the members of the public to make inputs. It is the NCOP through the provinces that will then take into consideration the inputs. For example, there are some suggestions about removing clause 33. We will just note it is up to the NCOP to decide whether they agree with the people, and then they will then amend it if they agree. And if they amend the bill, then it will go back to National Assembly again for reconsideration until there is consensus between the two houses. So the bill is in fact really a provincial bill now. It is the provinces that should deliberate as a result of the public hearing and decide when they go to the NCOP whether they are making any proposal or not. They can decide not to make any proposal and decide not to support the bill. But if they support the bill with amendment, they can also do that. Then that will be up to the NCOP plenary to accept. And if the NCOP plenary makes changes to the bill, then it will come back to us again to reconsider. So there was question about clause 54, which that deals with offenses that says any person who knowingly submit false information to the fund or its. So the word any person in law, it means any person because there are two persons. There is a natural person and there's a juristic person. So companies, when they are registered, they are regarded as persons or legal persons. So this clause want to cover both. The company may also submit false information. The private, meaning the healthcare service providers, some will be registered as companies and then they will claim as companies. So this any person wants to cover for that. And the issue of the 100,000 cap and the 5-year imprisonment, it will be up to the court to take into consideration the mitigating factors when they pass out the sentence, whether it will be 100,000 or the combined one. So, and if the public want to suggest that the 100,000 should go to 1 million, then the NCOP will consider that and make it, and maybe make a proposal back to the National Assembly. I think I covered all the questions that I can remember, sir. Thank you.
If I may, I want to remind you of two more. The one was will medical aid contributions cease? I think that's what the lady also asked. And then also the question from the gentleman from the City of Cape Town Health, the funding, will funding of municipal health services, how will that be affected?
Clause 33 talks about the ministers going to make a regulation on how the medical aid will continue to exist and clearly indicate that that will be for purpose of prescribing benefits that are not covered by the NHI fund, meaning that those will be complementary. And in terms of the municipal services, the bill creates a body that is going to fund, it's a funding model. It funds is going to reimburse the service providers, whether municipality or a public clinic or Tigerberg Hospital, they are going to claim from the same way that they are claiming from the medical aid when they are provided services. The Stibbigo Academic, for example, it has a lot of patients with medical aids who are going there. They are claiming medical aid is not meant for private hospitals only. You can to a public hospital and then they will pay. So it will be the same model. If the municipality, those that are able to provide health services and accredited and contracted with the fund, they will be able to provide service and claim from the fund like any other healthcare service provider. Thank you, sir.
Thank you, Mr. Mwabele. Ladies and gentlemen, were all your questions answered? Lady?
Chairperson, this section that I quoted, it explicitly says not exceeding. So the answer that the official just gave, that the courts makes the decision. The court will be guided by this section in this bill. It clearly says not exceeding. So it's not up to the court that can exceed that amount. And so my input would be that the NCOP need to look at that clause because it's very clear and the courts are guided by the acts. It doesn't suck things out of its thumb. It looks at what's in front of them.
Thank you. Mr. Mobello, do you wish to respond?
Yes, it is true what she's saying. Parliament is limiting the fine to up to 100,000. That is the maximum that the court can do. And then there's also a 5-year, but the court is also allowed to impose both fine and imprisonment. But the fine is not going to exceed 5 years. So it seems the public is saying the sentence is just too light, maybe considering the offenses. So the public can submit the proposal in terms of how much will be considered to be fair and just. And the NCOP will then consider it in that context. Thank you, Chair.
Thank you, Mr. Mobello. Ladies and gentlemen, were all questions answered? In that case, I'm going to ask the Honorable Njaru whether he wants to conclude for us. Honorable Njaru, over to you.
Thank you very much, Chairperson. Good afternoon to all the stakeholders and participants. From the National Council of Provinces, we are here to listen to the inputs and also to get written submissions. And just to have two reflections in terms of the government have an obligation to ensure every citizen equal quality access to health services, which is a must, which is in line with the Constitution. It's our obligation as government to make sure that every citizen get equal access to health services. Second comment is that to also, as the NCOP, we want to appreciate all the submissions, especially those who are in support of the transformation or to transform the current system, which is not serving every citizen equal health. 3 months ago, the National Council of Provinces Select Committee visited South Korea. And for knowledge exchange and best practices. South Korea, we also got advice on the implementation, which is in phases. South Korea fully implemented the national health insurance, which is working. So we went there and we get knowledge exchange and the best practices of the national health insurance. So therefore, where we are today is that the National Assembly have endorsed and it was referred to the National NCOP Select Committee, which is now at provinces for public hearings, and which will come back to the National Council of Provinces to table at the House, and then to be sent to the President to sign, and then to start the implementation of phases. Thank you very much, Chair.
Thank you, Honorable Njalu. Ladies and gentlemen, with that, we have basically come to the end of our proceedings. I would like to thank the Honorable Njalu for his attendance and presence, and that of my colleagues of the National Department of Health, of the Provincial Department of Health, and of course all of you for the contributions and inputs that you've made. It is much, much appreciated. It was necessary to have this session, for the processing of this bill. Thank you for that. There are refreshments in the members' lounge. I stress refreshments, not lunch. I wish you a very happy Heritage Weekend whenever it starts. This meeting is adjourned. Thank you. Yes.
We need to conduct a study. So,
Hey? Yeah.
it was
But-
follow up and that proposal, was the proposal that was submitted to the speaker during member Philander's time.